Sorry to surprise all of you. Welcome. This is the Public Safety Committee. I am the chair, Mark Conway, representative of the 4th District. Today we have with me Councilman Antonio Glover of the 13th District. There are a bunch of other members that are running just a little bit late that will be joining us shortly. Representing the Mayor's Office, I have Nina Themelis. Thank you, Nima. Representing the Office of the President, I have Shamoya Gardner. And I have Ethan Navarre from the Office of Council Services helping me out today. Today, the committee is meeting to discuss LO 25-0013, harm reduction and overdose prevention, introduced on Monday, February 10th, 2025, by myself, Councilman Conway, for the purpose of inviting representatives of the Baltimore City Fire Department, the Baltimore Police Department, the Office of Emergency Management, the Baltimore City Health Department, the Baltimore City State's Attorney's Office, the Maryland Department of Health, the U.S. Attorney for the District of Maryland, and advocates on this issue to discuss opioid use and overdose statistics in Baltimore and to devise pragmatic public health-centered solutions to the city and nationwide crisis. Folks, this has been, I think, a hearing a long time in coming. I pulled this together in part because I believe that it is incredibly important that we talk openly about this issue. My colleague, Councilwoman Porter, has held a number of meetings in the Health and Environment Committee I think are incredibly helpful and I think have started a robust dialogue. I believe that it is integral to the success of our city on this issue that we talk about it openly, that we get folks out of the shadows and out of, I think, some of the difficulties and shames that come with addiction to talk about what we're experiencing in our city if we're ever to reduce the number of people that are overdosing and dying, but then also to break the cycle of addiction. This is the first of 2 scheduled meetings in the Public Safety Committee. This first hearing is geared toward trying to first understand how we got here. If we all remember, a little over a year and a half ago, we unfortunately got a lot of not very good coverage about how things are going on in the city. And in that time, I think there's been a lot of attempts to address the issue. But once again, I do believe that in order to do so effectively, we need to be working together. This issue cannot be solved in closed-door rooms. It cannot be solved by really smart people working alone. It takes all of us. And in order for us to do so, we all need to understand our part and what we can do to support folks dealing with addiction and begin to as quickly as possible, dismantle what I see as a big problem for our city. We've had in the past couple of weeks, if folks can be quiet upstairs. In the past couple of weeks, we've had, unfortunately, a series of overdoses. First, 27 folks overdosed, and then the following week, 7 additional folks overdosed that we know of from an event in Penn North, showing that there's a lot of work that still needs to be done on this issue, and that we still have progress to make. I'd say personally, in my experience on this council, I've come across at least 3 folks who have overdosed in my personal experience. Twice in front of my district office on York Road, once in which I had to specifically go out there and try and find my own dosage of naloxone. Fortunately, that person woke up and was able to get back on his feet before I had to apply it. But it just shows really the urgency and the fact that, this can really be affecting people anywhere. I think, another story that was deeply personal for me was while I was knocking doors, running for office, and I had an opportunity to meet a family with 2 daughters the same age as my young children. And they talked about their experience trying to get support and trying to get help, and how they failed multiple times to get on their path to recovery, but finally did find some stability in their life once they had children. And as a father, I can only imagine the difficulty of being in that situation, knowing that you have young kids counting on you to get things in order. So I think this is an issue that not only affects folks who are specifically dealing with addiction, but it also affects their children. It affects their mothers, their fathers, their families, their jobs, their coworkers, people who care about them. And so I think it's really, really, really important that we get this right, which is why I wanted to make sure that we pulled everybody I could together to have this conversation and to continue to move this issue forward. The city recently, a couple of weeks ago, put out both a needs assessment plan and a draft plan for how we plan to address opioids across the city. I think it's a great start. I think, though, it's not until we have these opportunities to learn about how we got here, learn about what we're already doing about it, and then learn about what we plan to do about it, that we identify those additional nooks and crannies and gaps that only people who are in the street have perspective on in order to be truly effective. So my hope is that today, we all here in person or watching this in retrospect can walk away with a deep understanding of what got us here, so that we can figure out what will get us out of this situation. So with that, I'm really looking forward to hearing from the agencies. I've invited a number of panelists that will be able to share their perspective on what they've seen on this issue in the many years that they've been working on it across the city. And then I'll open up to hear from our colleagues and learn as much as we can. There will be an opportunity for testimony at the end. So I offer that up to folks that wish to testify. But once again, looking really forward to really digging into this issue and doing everything that we can. I want to thank everybody who's here to participate and to add their insight. We need you. We're counting on you. So with that, I want to acknowledge my vice chair, Councilman Blanchard, who's just joined the meeting.
Thank you, Mr. Chair.
We have in attendance today, we have the fire department, we've got the health department, we've got Mac Clinics, we've got the Baltimore Harm Reduction Coalition, who are also joining us. We've got the Baltimore City Police Department here in Forest. We've got the Mayor's Office of Overdose Response here as well, and the Johns Hopkins School of Medicine and Public Health also joining us to provide some expert perspective. So with that, I'm going to hand off to a panel that we have here today. I'm going to give each member of that panel a few minutes to talk about what they see, what they know, and provide some additional perspective. Once we go through the panel, I'll provide an opportunity for each member of the council to ask one question before we then hand off to our city agencies who will then walk us through their respective presentations. So first up, I have Kelly Mayer from Mac Clinics. Kelly, if you could press the button on the right, it'll turn on. There we
Awesome.
go. And if you could say your name for the record and your affiliation, and then you can jump right into it.
This is Kelly Marr. I'm the Director of Counseling at Mac Clinics. I'm happy to answer any questions. Just a little bit about me and us. So Mac Clinics is one of the largest OBOTS, outpatient addiction groups in Maryland. We have 8 offices across the state. We're seeing over 2,200 patients. So we have a lot of people that we're helping. There's still a lot more people that we could be helping. We provide low threshold to buprenorphine, so Suboxone access, as well as treatment for alcohol and other substance use disorders. We provide a broad range of behavioral health services as well, therapy, counseling, psychiatry. Over to the right, I think it's really important that we highlight how patients are referred to treatment. There are a lot of treatment providers out there. Quality is really important over quantity. We get people from the criminal justice system, we get people from the emergency rooms, EMS, social services, and we triage them, assess them to see what kind of services they need, outpatient, intensive outpatient, inpatient, or recovery housing. We also get a lot of people who self-refer as well. And I think it's really important that we identify that treatment alone is not necessary to rehabilitate people. So we need to work collectively. I have a second slide. So I think it's really, really important that we understand that there's mismatches in care, and that makes people kind of steer away from treatment. They're less likely to stay engaged if they feel like they're being set with a level of care that's not attainable or sustainable. We follow the ASAM criteria, which tells us which level of care is going to be the best fit for somebody. In our clinics, more than 85% of our patients respond really well to outpatient levels of care. We really want to make sure that we're saving the resources for more intensive levels of care for people that truly need that. It's going to be a better use of our resources, and it's going to keep those people engaged. I guess that's mostly what I think is important, is understanding kind of where people are coming from when they get treatment, how we make our decisions on what levels of care, and making sure that everybody understands how these decisions are being made. That's all.
Thank you, Kelly. And so for context, I've been talking a lot with Matt Clinics about some of what they've seen in the clinical space or in the treatment space. And so it helps, I think, to hear from you guys about that piece of the pie and where we see opportunities there. So I appreciate you guys for coming here today. Next up, I've got Candy Kerr.
Ooh, this button. Great. My name is Candy Kerr. I am from Baltimore Harm Reduction Coalition. We are a harm reduction organization that has been operating in this capacity since 2017. We define harm reduction as an evidence-based intervention for criminally stigmatized behaviors, so drug use and sex work typically. And so, yeah, I'm here to talk about one part of the solution, right? Statistics are, we get our data, we turn them into we don't turn them into statistics, y'all do that. So we get the data, we send it to different places, Baltimore City and Maryland. And so I'm gonna let them talk more about the statistics, and we're gonna talk about the strategies that we have within the city and within the US. So current harm reduction strategies that we have within Baltimore City, right now we have 8 authorized syringe service programs in Baltimore City. Syringe service programs are programs that hand out new supplies. So in the picture, you can see different supplies that people use for their drug use. So we hand those things out, but we also hand out like menstruation kits, safer sex kits, things that have been proven to reduce transmission of HIV, Hep C, and we also hand out wound care kits, especially right now. Wounds have been, in the last few years, wounds have been starting to look a little different. And so we started handing out wound care kits as well. SSP participants are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs. As a harm reduction organization, our goal is to not move people into treatment. Our goal is to meet people where they're at and not leave them there, right? So we meet people where they're at, and the not leaving them there part looks like handing out referrals when asked to different agencies in different places, and also like it's usually inner city referrals that we give. And so, yeah, we have 8 authorized SSPs. The city also has ORPs, so overdose response programs. There's like 42. That number, 42 is what I got, so there might be more. And they're authorized to distribute naloxone. And so SSPs do that also. Drop-in centers in the city. So I think we have 4-ish. So Charm City Care Connection, Baltimore Safe Haven, which may also be known as Maryland Safe Haven, Charm City Spark, Baltimore Harm Reduction Coalition does like drop by. And so these are places where people can come in and again, they can receive different kinds of services. So low barrier access to services. Are you giving me the look to stop talking? Okay, cool. You're just nodding. Okay, cool. I talk a lot, and so I was just checking. So low barrier access to services, similar to the ones that I named earlier, right? Case management, clothing closets, showers, food options, community, things like community is a big aspect, right? So this is a place where people can come in. Charm City Care Connection is that picture below. And so that picture is their like storage room. But in front of that is a space where people can come in, they can sit down, they can be waiting for their case management or their case manager to become available. And in that space, they can take a shower. There are different food options that they're given. They can ask to go into the clothes closet. And they can also spend time with people from the community in that space, right? And also, like, it's a reprieve from how hot it is, or how cold it is, or how wet it is outside. And so we have, like I said, like 4 or maybe 4 to 6 of those in the city right now. And on the slide, I just wanted to give a shout out to those community-based organizations and other harm reduction organizations that have been in the city and the state, but the city very specifically. Some of the ones that I've named, also Healthcare for the Homeless. I started at Be More Power. And so, yeah, just shout out to those groups for doing that kind of work. A lot of these, like a drop-in center is like on the ground. People say boots on the ground. That's a boots on the ground situation. And a lot of different syringe service programs are similar. And then next one, and I'll be done. Okay, so current harm reduction strategies in other states, which I wish was in the city, overdose prevention centers. This is something I talk about consistently every second of every day. It's probably irritating to most people I know, but overdose prevention centers are a bridge to treatment and healthcare, and they have social services, right? For the isolated and vulnerable community members, that we have, again, referrals, right? You can hear this like refrain of like referrals, 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 like these strategies are meeting people and giving referrals, and then that is huge. Whenever people feel comfortable and feel like human beings are more receptive to having referrals. Those referrals include substance use treatment, housing, mental health supports, wound care, and more. Brings people off the streets, similar to what I mentioned before. This one pictured is in New York City and has been visited by the mayor, a few different city council members, names that I cannot remember, police commissioner, the fire chief, that gentleman over there. Quite a few members have gone to see it. And one of the features of this is it also has a wellness room. Like, we are talking about human beings that are using drugs. They are human beings first and foremost, and there's a wellness room where people can go in and have acupuncture. They can rest, they can do the things they need. And then the bottom one is actually the first one, right? Overdose prevention at its finest. Personnel trained in overdose prevention to help those in need of immediate intervention. This results in fewer ambulance calls, emergency room visits, hospitalizations, fewer incidents of people having to do those interventions on the street, finding people on the street. They're using those supplies in a space, and so those supplies are disposed of in the actual space, which can also be helpful for the community outside. So that is a strategy I would love to see in the city. I know that Mayor Brandon Scott has been vocal about them for a while. And there are other strategies, but those are the ones that I wanted to name and wanted to talk about. And I just wanted to say thank you for having me here to be able to do that.
Thank you, Candy. And I speaking to my opening statement and how important it is that we bring this work and these issues out from the shadows, I really appreciate the work that the Harm Reduction Coalition does to do that, meeting people where they are and making sure that we support people in every which way that we can. The health department will go into this data a little bit, but one of the interesting things that we found in the data is that roughly 55% of overdose deaths happen in people's homes, and that's when they're alone. And we could avoid a lot of these deaths if we are more strategic about how people are using so that they don't put themselves at risk. So really appreciate the work that you guys are doing, and look forward to continuing to work with you.
I have one question before we go on. Is that knocking in my imagination or is someone doing work over there?
It's not in your imagination.
Okay, someone's like doing work on the other side?
They are.
Okay,
yes.
cool, thanks.
Next up, I've got Dr. Megan Baresh. She is from the Johns Hopkins School of Medicine. Dr. Baresh. And you press the button on the right. Wonderful.
All right. Thank you, Councilman Conway, and everyone for having me. I'm Dr. Megan Burish. I'm a primary care and addiction medicine physician at Johns Hopkins Bayview, an associate professor of medicine at the School of Medicine. Every day I work on the front lines of the opioid crisis. As a primary care doctor, I provide buprenorphine to over 100 primary care patients who are in long-term recovery, and they can come and get their other care. Because it's part of just general primary care, they're not disclosing the fact that they have addiction. And I also I treat faculty members with and without addiction. I treat nurses, I treat professionals, people who are working and you would never know are on this medicine because they're restored to their lives. On Wednesday mornings, I'm outside the Baltimore City Detention Center doing low-threshold buprenorphine with the BHLI P-Care van, who I know has testified before and has treated thousands of patients who otherwise didn't think treatment was for them. And many have primary care and access other healthcare, other places, but they were using drugs kind of in silence. And then since 2017, I've been the medical director of Bayview's inpatient addiction consult service. So over 10% of patients hospitalized at Johns Hopkins Bayview have opiate use disorder. It's one of the highest rates in the country. And so I lead a team of addiction medicine doctors, social workers, peer recovery coaches to get people evidence-based treatment, especially the life-saving medications, buprenorphine and methadone, and then to link them to ongoing care and think about the transitions of care. And I can't highlight enough the importance of peers in this work and the ongoing work. And then since it started in 2017, we've treated over 5,000 patients, but we see the gaps in care. So we are seeing, as was mentioned, increasing wounds related to adulterants like xylazine. We see people who were really, really sick with bloodstream infections, wounds, deep bone infections that require increased medical care. And addiction treatment centers, like recovery houses, don't want to take anyone that has even a basic wound. And medical centers, like skilled nursing facilities, don't want to treat anyone with addiction. And so people have to choose which disease, and addiction is a disease, gets treated. And so a lot of my work is trying to battle the stigma in the healthcare system, but we definitely see gaps in access to treatment. I just want to add, this is personal to me. I lived in the North Patterson Park neighborhood for 13 years and still own a home there. I love Baltimore. I grew up in the area. I specifically returned after my medical residency to provide treatment where it's both needed. I've picked up used needles from my alley. I've had to warn my nephews about needles in why my nephews from Tennessee couldn't play in the Leafs. I've lost friends and neighbors to overdoses. And every day I see treatment that saves lives. And the tragedy is that each one of these deaths is preventable because we have the tools, but there's a lot of great work going on, but we're not getting where it needs it. I could tell a lot of stories, and I can't share too many personal details of patients, but through the work on the consult service, we often start people on medication, and then we make sure there's ongoing care, especially if our primary care clinic at Bayview. And the one person I saw, he had advanced liver disease, he was in the hospital. He wasn't even seeking treatment per se, but it was an opportunity. We got him started on buprenorphine, and I still see him 8 years later. He still uses fentanyl some, but he's alive. He's still on bupe. He has housing. He hasn't been arrested, he hasn't had overdoses, and he stayed out of jail. And there are hundreds more I could share. And I do want to also highlight some of the harm reduction strategies others have mentioned already, that we need these life-saving treatments and access to treatment, but we have to keep people alive until they're ready and able to access treatment. We need to fight the shame and stigma that leads people to use drugs alone. And as Council Conway mentioned, the majority of overdose deaths in Baltimore City happen when people use alone, either in their own homes, others' homes, abandoned row houses, the places that they call home. And with an increasingly deadly drug supply dominated by fentanyl, adulterants like xylazine and medetomidine, we need harm reduction measures like drug checking so people using drugs know what they're using and first responders can treat them appropriately. We need greater transparency of the real-time overdose data and hotspots so that we can respond with targeted resources. I've sat on the City Health Department overdose fatality review. It's amazing. There's amazing data, but as a practitioner and other people can't access that great data. And then I also wanted to highlight OPCs. We did not coordinate our statements. So just highlighting that they're places, they're evidence-based, they've been used in decades in Canada and Europe. We now have the first legal OPC. There's been many illegal OPCs in the US in On-Point N1C, which was pictured by the previous speaker. A couple statistics since they opened in 2021. Over 1,800 overdoses have been treated. No fatal overdoses because naloxone is right there. And there's Insight in Vancouver that's been operating for over 20 years and more. But for the US case, 3 million units of hazardous waste has been collected, so that's like the used needles, so that's not on the street and in the neighborhood. And $53 million in savings to taxpayers through measures like they're responding to overdoses so that police don't have to. And it's been really integrated in the neighborhood. They employ people from the neighborhood. They have a daycare, it's been really great for kids there. So we've been in the forefront in Baltimore through harm reduction since the 90s. We were one of the first places in the US that had syringe service programs. And at the time, syringe service programs were criticized as encouraging drug use, but they've saved lives. They've led many people to eventually stop using drugs because they were people first and human beings first. OPCs are similar. They don't encourage drug use, they don't increase drug use, but they help make it safer for the people using drugs and also our communities. And then I would just say, well, there's the targeted responses are specifically about opioids and people who use opioids in this way. We really need to address the structural inequities like housing, homelessness, partnerships like Build to address vacant housing, I think are good examples, but there's so many times, people can't do recovery if they don't have safe housing. So thank you.
Thank you, Dr. Baresh, and appreciate you coming out and providing some insight. Next, we have Dr. Javier Cepeda from the Johns Hopkins School of Public Health.
Hi, good afternoon. I'd like to thank the esteemed members of the Baltimore City Council for the opportunity to speak about the role of public safety on addressing the overdose crisis in Baltimore. My name is Javier Cepeda. I'm an assistant professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, and I'm speaking in my capacity as an independent investigator. I've been studying substance use, infectious disease, and public safety for over 15 years in both domestic and international settings, and have received multiple grants as a principal investigator. I'm also co-investigator on the AIDS linked to the intravenous experience, the ALIVE study, which has been working to understand drug use in Baltimore for over 40 years. I have dedicated most of my research career to studying the intersection of public safety and public health because I want people to be both safe and healthy. Today I'd like to make 3 points. First, traditional policing has historically posed a risk to public health. Second, innovative policing alternatives can improve health. And third, strengthening public health and public safety together is mutually beneficial. So let me explain some of these points in turn. First, traditional policing has historically posed a risk to public health. Over-policing of low-level, non-violent drug offenses resulted in explosive growth of jails and prisons across the nation. Release from incarceration is a strong risk factor for subsequent overdose, particularly within the first few weeks of release after reentry into the community. This is because tolerance to opioids decreases during periods of abstinence, such as when someone is incarcerated. It's also important to recognize that regardless of arrest, even the perception of fear of arrest keeps people away from treatment and other essential services. These problems are why many police officers will say, we can't arrest our way out of this problem, as this revolving door of people constantly cycling through the justice system does not help public health or public safety and fuels burnout among law enforcement officers. So let me turn to my second point. Innovative policing alternatives can improve health. For my own research, we have built capacity in multiple law enforcement organizations on the science behind addiction, occupational safety, evidence-based harm reduction, and treatment services. Through this training, we have shown significant declines in occupational stress and burnout and greater self-efficacy for law enforcement officers to make referrals to health and social services for people who use drugs. The overall goal of my research is to improve the interface between public safety and public health by task shifting the role of street-level policing to behavioral health services. This brings me to my third point. Strengthening public safety and public health together is mutually beneficial. If pathways exist for law enforcement officers to efficiently refer people who use drugs to behavioral health services, then law enforcement will have more time to focus on fighting violent crime and making communities safe, and more people who use drugs will get the help they need. So I'd like to conclude by saying that it is critical that everyone involved in this response hear the success stories. First responders often see individuals at their most vulnerable and can reach the conclusion that there is no hope. But many individuals do recover from substance use disorder. It's just that these stories are rarely told. But my research has demonstrated that these success stories can not only help destigmatize drug use, but might also help ensure sustainability of these evidence-based interventions. Thank you.
Thank you, Dr. Cepeda. Appreciate you coming today. Next up, I've got Dr. Michael Fingerhood from the Johns Hopkins School of Public Health.
Thank you for allowing me to share my insights. The last time I was actually in this building was 2006 when I stood next to Mayor O'Malley as he introduced the Baltimore Buprenorphine Initiative. We made progress, but there's obviously lots to still happen. For the past 35 years, I've been on a mission to provide compassionate, non-stigmatized care to individuals in Baltimore with addiction. I'm a professor of medicine and public health at Johns Hopkins, but most important to me is actually the clinical work that I do. In 1994, I created a primary care practice that you heard about at Johns Hopkins Bayview Medical Center, focusing on providing integrated care with compassion to patients with addiction. We have a total of over 650 individuals with opioid use disorder. I still see patients there 3 sessions a week. And we've been able to show providing integrated care that we, for patients with Medicaid, that we save money over previous models of siloed care, or the more dominant mode of patients go one place for addiction care, another place for primary care. Within the clinic, importantly, we have a food pantry providing food from the Maryland Food Bank, and have a Hopkins Community Connection office, a group of amazing 16 to 20 Hopkins undergraduates who help our patients with social determinants of health. So that has to be an important piece of how we take care of patients. However, I also realized that we can not always expect patients to come to us, meaning a typical medical setting, and have worked on establishing community-based low-threshold sites in Baltimore. In 2009, I worked with BHLI. We heard about the Beat Care Van, which I'll mention in a second, to create a buprenorphine program at Dee's Place in East Baltimore. There was work to establish trust in the community. Hopkins didn't always have a positive view from the community, and we had to work toward that and building trust. And we also had to work towards the traditional view in many people in recovery that medication is not part of recovery, or if you're on medication, you're not in recovery. The majority of individuals we reached there had never been in treatment previously, and none had been on buprenorphine. The program has since moved on to Amazing Grace Church in East Baltimore, where on Monday mornings, I care for individuals with opioid use disorder by prescribed buprenorphine. I was there yesterday morning. Our team consists of a nurse, a peer counselor, and myself. Most of the individuals had never been in treatment for opioid use disorder previously, and most are Black men over the age of 50. One gentleman I saw yesterday that I thought I'd share is 71 and came to us 3 years ago seeking treatment for the first time. He'd been using since he was in his 20s. He avoided going for medical care for fear of being judged related to addiction. And I'll just say Pastor Gary Dittman at Amazing Grace Church has been a wonderful partner. He also hosts Save Streets, and we also have people from Trump City Care Connection come over and help the community by removing drug paraphernalia from the areas around the church and really the blocks around the community there. I'm also a consultant for the Maryland Addiction Council Service, providing all day on Thursday help to providers by phone to help them take care of individuals with addiction. Also on the boards of the Trump City Care Connection and BHLI, so both very dear to my heart. And I try to provide guidance in reaching as many individuals with addiction as possible, because touch points are crucial. So, the only way we create hope for people is by taking advantage of touch points. And my definition of recovery is making today better than yesterday, and that's what we have to do for our individuals as we see them at sites away from typical medical settings. I'm also on the Beat Core Steering Committee now as we try to set up effective entry points of care, including all city emergency rooms, EMS calls, the Baltimore City Health Department spot van, which I think you'll hear about, and the BHLI van that you just heard about as well, which sits outside the detention center. We do have to do a much better job. It's as you've heard twice now, that individuals are released from incarceration without being treated for opioid use disorder, and that if they are going to be released for home detention, they cannot be on medication for opioid use disorder. So there's a choice that has to be made at the point of release for home detention, that if they're going to be on home detention, they have to be taken off medication. In my faculty role, I cover inpatient addiction medicine consult service, or inpatient addiction medicine 8 weeks a year, as you heard. And that really informs us on current trends in drug use and what's happening on the street. I was asked, where do you go? How much do you pay? What's different on the street? What happened the last couple of weeks ago, I've had patients have a phone in front of them and say, oh, there are testers on the corner of such and such. So we have to understand how that happens and how individuals become so vulnerable as a result. And finally, in order to create new compassionate clinicians and researchers in addiction, I teach and mentor at the medical school and at the Bloomberg School of Public Health. Thank you.
Thank you, Dr. Fingerhood, and appreciate you for taking the time to come today. I understand you guys might have to leave a little bit early, but feel free to do that when you feel necessary. I want to acknowledge two other members of the committee that have joined us during the last couple of presentations, that being Councilman Porter of the 10th District and Councilman Gray of the 8th District. Last but not least, we have Kyle McDermott. Kyle is a former investigation manager with the Health Department under the COVID-19 program. If you could press the button on the right and just say your name again for the record.
Kyle McDermott.
Thank you, Kyle. Can you tell us your role at the Health Department and what it entailed?
Yeah, I worked for the Health Department from November 2020 through June of 2024. I was hired into the COVID program. I was an investigation manager. I oversaw a team of 6, and I was primarily assigned to the behavioral health and homeless care systems.
And what is the Health Department's relationship with the behavioral health facilities, especially those concerned with people living with substance use disorder?
Prior to COVID or since COVID? I'm not familiar prior to my employment there. I don't think it was especially strong. The Health Department is very underfunded. I think that one of the hallmarks of what my team did was build relationships in the community where none had existed previously. And so there's more than probably 100 organizations that we had contact with, that we built relationships with, that welcomed us into their facility. And so we established good rapport with them. I think that was when I left at the end of the COVID program, that was one of the, one of the strengths was that, that those relationships were there. And I don't think anything really developed from it, but.
Do you have any past professional experience with substance use?
Yeah, I mean, I pretty much spent my life dealing with this. I grew up in a home with addiction. I found my first dead body when I was 14, watched a person overdose.
Sorry.
Subsequently struggled with addiction myself. I was homeless when I was 25. And that sort of experience, I segued into public health. My first public health job was on the front lines of the opioid epidemic in Vermont. This was, at the nascent fentanyl crisis. And at the time, Vermont was leading the country. I mean, the governor in 2014 had declared a public health emergency. It was the first in the nation. And then they implemented the spoken hub model and became a model for the rest of the country. So I did about 1.5 years of that. It was 60 hours a week, 6 days a week. I worked with about 300 clients. We were a 3.7 level program, which is the second highest level, 28-day program. We also had detox, and then we had a 3.1 and, 3.3, which was like a supportive housing halfway type, that they continue receiving treatment. They may be enrolled in medication-assisted therapy, and they're provided housing, and it's sort of a way for them to rehabilitate their lives and get back into the community.
How did the COVID-19 pandemic impact people dealing with substance use disorder?
Well, overdoses skyrocketed, right? We know that isolation is one of the factors of overdose. People use in isolation. There's a lot of stigma around it. I mean, obviously, you're not going to shoot up in front of coworkers, but it exists everywhere. It's prevalent. And I just think the isolation and the uncertainty of that pandemic really just got in people's heads, and eventually you get to the point where you're just asking, like, what am I living for?
And when did your concern about the pandemic's effect on drug overdoses rise?
On the rise?
Yeah. When did you begin to worry about it?
When did I become worried about it? I mean, I've always been worried about it. That's how I got into this business. I mean, when I started, I think overdoses nationally were in the 60,000. and then it went to 80, and then it skyrocketed during COVID. I think it peaked at 106 or 108 in 2021. So well known, it was in the media, concerning, right? I think that it was probably more concerning to me because it was personal. You know, I've lost friends. I've been close to death multiple times, so.
And so the deaths from COVID were where compared to?
Oh, are you talking about in the city of Baltimore?
Yeah.
Yeah, so I mean, during that 4-year period between 2020 and 2024, COVID deaths were somewhere like 2,200, and then overdose deaths were 4,000 and some change. So you were twice as many people died from an overdose in Baltimore City during that 4-year period than from COVID-19.
Wow. Did you bring this up to folks, to your superiors at the department?
I was concerned about it. I mean, this is like my career, even though I was working with the behavioral health system on COVID, you know, my focus was on people and addiction and helping them. So I think in it was late spring, May of 2021, COVID was sort of slowing down. I had more time to talk with my bosses. And so one of the things that I brought up was, what is the health department's response to the overdose crisis?
Did you?
And how we could help, right? That was, you know, where I was getting at with that question was like, we have a team who is working with the behavioral health population. We have more contact than we've ever had. We have all these relationships. Like, can we support overdose prevention in some way? How can we help with that? And I'll say one thing to that is, we were grant funded through COVID money, so I was restricted from working on other things. But as far as like the knowledge that we had and the relationships that we had, we were never invited into a planning meeting or any, you know, no conversation was had with us regarding overdose prevention. And so when I asked, you know, what can we do? The response that I got was, it's not a priority. It just was not on the radar of the health department. And the city of Baltimore, and the mayor's office as well.
So you were told that it was not a priority?
Yeah, those were the words. Yeah, we looked at each other. There was 2 bosses in that meeting. One was the current assistant commissioner, and then the second person later became the assistant commissioner. And there was a moment of pause, and we just looked at each other like, this doesn't make sense, because there's people dying. But I'll say that those 2 individuals did not work on overdose prevention. Those 2 bosses were not directly involved with it, but the information that I got was credible because it was coming from the office of the health commissioner.
Got it. Thank you, Kyle. Folks, I'm going to offer an opportunity for one question before we get to the agencies of all of our panelists.
If I may add one more thing, or a couple things. One, sure. I don't think anything that I've said is a major revelation. I think the banner pointed that out, and they did very good work. I'm somebody who's, I guess, frustrated and angry. And so for a while, I've just been after the truth. I've had conversations with people inside the health department off the record, and I sort of got an understanding of what happened. There's 2 things that I'm really curious about is, like, you know, what do we learn from this? What more could we have done? And, you know, part of that is like, well, what's the process of government? You know, I was a mid-level manager. I'm not involved in budgeting requests, but I'd be really curious to see what population health was doing during those 4 years and what they were requesting and what happened with those requests. And I assume that's public knowledge. I don't know how to get it. I've not researched it. But I'm really curious to know where those requests died and who did they die with.
Thank you, Kyle. I want to welcome Council President Cohen to the hearing. Council President, any words you want to say?
No, please.
We are offering a round of questions for the panel. Everyone has had an opportunity to present. I'm going to start on this end with Councilman Glover.
Thank you, Mr. Chair.
And one question.
It's fine.
Yep.
Okay. So my question is, sort of, what are we doing? So this hits me personally. Like, I mean, just last year, I lost an uncle and a cousin to overdose, drugged out in the alley, left there because of the education was not probably provided to those who they were getting high with, right? They felt like, if they died on my watch, then I may get incarcerated, things of that nature. So that's what occurred. But it's affected many people, like in my family, in my community, right? What I've seen today in this time is so much different than what I've seen back when I was growing up, like in the 70s. Like my peers, my homeboys, we had rec centers, we had opportunities, we played ball. So that's what we enjoyed doing. Today, what I'm seeing is a lot of young people that are overdosing, that are getting high, that are basically getting high off their own supply, right? And what are we doing, as a city, as a community, to give them the help and the services that they need? Because even recently in the Montgomery Park community, we were able to help maybe close to 11 individuals that were homeless living in an encampment in the back of Montgomery Park. But is it fair to the community, right, that has overcome those challenges at one point in time, now being faced with it coming back again? Like we created home ownership, individuals had come to Baltimore to live, but now what we see is that a growth of addiction, homelessness, and addicts back in our community. And to be frankly honest with you guys, they don't look like me, right? And when I approach those individuals, I ask them, where do you come from? And many say Harford County, Anne Arundel County, Baltimore County. And I ask them, why do you cop? Why do you buy drugs in my district? And what they say to me is that the open drug market is there for them to purchase it and nobody's going to harm them. So what do we got to do to crunch and combat that problem that we're having in our communities? Because what it seems to me is that, and I'm in East Baltimore, not too far from Hopkins, but what it seems to me is that we're allowing these individuals to come into a community which is very, very, at times high in crime, but also which is very poor. And it's like we're putting them in an area to the point they say, you know what, it's okay to get high here. I heard earlier the young man mention that Amazing Grace has taken up some of the slack and has provided medication, things of the nature for that population. But what I want to add is that, I understand the church is providing and helping those individuals, but the pastor don't live in that community, right? And it's like we're being forced to allow this to happen in our community when me, myself, and I'm keeping this real with you, I don't have a problem with bringing those individuals to the pastor home and let them do it in front of their home, because it's just not right that the community in which I live in, that we have made so many changes across these years,
Councilman.
that we're allowing it to come back into my community, and it's not fair. And I'm saying that I'm tired of it. And if you want me to be Tony or Poochie from the neighborhood, that's what I'll do. I'll bring them to where you guys are located at, because it's not fair to the community where I was born and raised, that village that made that change, and now I see them coming back again. I know they need help. Those family members that passed away, that died, they were only 2 blocks away from Montgomery Park. The services are needed. I am tired. I'm quite sure you guys are tired as well. But we gotta stop talking and do something about it, and we gotta do something about it like right now. We're in a crisis and it needs to happen now.
Councilman.
So I apologize for going a little over the minutes, but this is where I'm from, right? I see it every day. It's been in my family. It's my friends. Some of them are educators who have taught me, and I see them out there getting high now. Coaches. This cannot happen, because what I'm saying now is that young people my kids' age, 13, 14, 15, are getting high on drugs, overdose, and families are leaving our children. It has to stop now. So I apologize to my colleagues and to the council for
Appreciate your passion,
going over it,
Councilman.
but this is where I come from, and I'm tired of saying what I'm tired of saying, and we got to do something about it.
I appreciate your passion, Councilman. And we're going to have an opportunity to hear directly from the agencies right after this. I do think, to echo your point, the issues that we see in our communities aren't unacceptable. And I think we want to see a comprehensive effort around certainly our open air drug markets, as you mentioned. We're going to hear a little bit from, of course, the health department on some of the addiction pieces, and of course, the police department on some of those components as well. But I agree with everything you just said. Councilman Blanchard, any questions?
Not at this time. Thank you, Mr. Chair.
Councilman Porter?
Thank you so much. I have a quick question about just the MAT clinics. When you all talk about deploying naloxone, how long do you all have to stay there in order to deploy that medication to said individual? So for example, I see your face, so I'm gonna explain. So when a person overdoses, you can't just apply buprenorphine to a said person. So how long do you all have to be there in order to deploy that medication?
Are you asking when somebody is overdosing at our clinic?
Can you speak into the mic?
Are you asking if somebody were to overdose at our clinic?
Yes. Mm-hmm.
I will say, fortunately, this doesn't really happen very
Okay.
often in our clinics. We have 8 offices. We don't experience that.
Mm-hmm.
We are one of the largest naloxone distributors in the state,
Mm-hmm.
and so we send a lot of that home. We prescribe it to people when they go to the pharmacy to pick up their medication. So we don't see a lot of it in the office.
Okay.
One thing that we're hoping is that by partnering with other like community agencies, we can be able to administer buprenorphine pretty close after an overdose occurs.
Okay.
The specific time
Do you know how long it is
before you can administer
before you
that,
can administer buprenorphine?
I don't know the exact time. I think maybe Dr. Baresh could probably respond better as a clinician.
So it's a good question. Basically, once you've given the naloxone, the Narcan, they've already gone into withdrawal.
Yep.
So you can give the bupe immediately after.
Oh, interesting.
Yeah, and you actually want to give it close after because the naloxone will wear after a few minutes, and then they would feel sick from the bupe. But you
Okay.
could basically, and this is, I think will be talked
So is that
about.
like a peer model? Because I know Frederick County, they actually have peers that do that.
Well, it's starting to happen through EMS and first responders.
Yeah, but also
No.
peers are associated with that as well.
They're helpful, and others can speak more to those programs, but the people administering the medication are the
Yes.
first responders.
Okay. And in the state of Maryland, they can do that? Okay. All right, cool. Thank you.
Councilman Gray? No questions. I want to thank the panel for contributing. You guys are going to be really important partners as we continue forward. I will, of course, share all these contacts with you, Chairwoman Porter, because I think they'll be helpful in the efforts that you're doing in your committee as well. We're all going to have to work together on this, and certainly our city agencies are going to be integral toward these efforts, but working with our partners at Hopkins, Maryland, Baltimore Harm Reduction Coalition, and otherwise are going to be really, really important in making sure that we're getting the access and the relationships that we need to get things done. So I want to thank you guys. I'm going to turn over to the Health Department, which I believe has a presentation. Thank you, Kyle.
Chair Conway, happy to go first, but I think
Oh.
we were going to have BC Moore go first. Yeah.
Whatever order you guys need to do your thing, please go for it. And please, of course, say your name and affiliation for the record. Thank you.
We have slides too. But thank you, Chairman Conway and members of the committee for convening this hearing today. My name is Sarah Whaley, and I'm the Executive Director of Baltimore City Mayor's Office of Overdose Response. Today, you've already heard examples of the immensely important work being done across the city by harm reduction organizations and our clinical partners. My city colleagues are going to share even more examples of the life-saving work that they do to prevent overdoses and reduce the harms for people who use drugs. Chairman, as you mentioned at the beginning of this hearing, this work can't be done alone or in silos. And the examples that are being shared today are examples of a collective mission of those folks in this room, the mission to save lives from preventable death. That collective mission shows the alignment of the work being done here and what is outlined in the city's overdose response strategic plan. This plan's aim is to be a roadmap for this collective work. So before I hand it off to my colleagues to talk about that work, I just want to ground us in a little bit of background in the strategic plan, and it will be quick because I know that a lot of you in this room have heard this already. But last year, Mayor Scott signed an executive order to guide the use of the opioid restitution funds. In this executive order, he created the Office of Overdose Response to act as point person to help organize and facilitate the collaboration of city agencies and community partners. The executive order established a restitution advisory board of community members with expertise, both personal and professional, with the overdose crisis to help weigh in on the use of the opioid restitution funds. And the executive order called for the development of an overdose response strategic plan that was informed by a citywide needs assessment. Next slide. This needs assessment was led by the Baltimore City Health Department and has informed the draft overdose response strategic plan that is out right now for public comment. The strategic plan will guide fiscal priorities for the use of the opioid restitution funds. Those investments will be made, and then monitoring of those investments will lead into a cycle of how we will oversee the restitution funds. Next slide. The needs assessment this year ended with 5 key recommendations for the city to address inequities, to dismantle silos and improve connections, to confront stigma, to increase access to low barrier services, and to improve the quality of the services across the city. Next slide. Those recommendations became the priorities of the overdose response strategic plan. And with those priorities, our goal is to reduce fatal overdoses in the city by 40% by 2040. Next slide. The strategic plan is made up of those 5 priority areas that are broken down into a set of strategies and then further broken down into specific activities. Next slide. And those activities will be conducted by city agencies, community providers, or other partners operating in Baltimore City. And this includes our state partners as well. The collaboration kind of goes across all of these stakeholder groups. And so with that, I will pass it off to the Baltimore City Health Department. Thank you.
Thank you, Director Whaley. Good afternoon, Chair Conway, Vice Chair Blanchard, members of the Public Safety Committee, and other members of council who are here today. My name is Jennifer Martin. I'm Deputy Commissioner for Population Health and Disease Prevention at the Baltimore City Health Department. Next slide, please. So in our presentation today, we're going to address specific questions that were posed to us by Councilman Conway. And our agenda for the presentation today is to talk about the behavioral health ecosystem here in Baltimore City, the history of the opioid crisis in Baltimore, to look specifically at some data trends here in Baltimore City. And then specifically, we're going to talk about naloxone distribution efforts in the city, as well as treatment access. These are only 2 public health strategies or interventions. Obviously, there are many more, and we plan to discuss other interventions at the second hearing scheduled in September. Next slide, please. Just quickly, this slide outlines some of the various data sources that we'll be referring to in the presentation. First, some of the data is qualitative that was gathered via a citywide survey, key informant interviews, and listening sessions that were conducted as part of the city's overdose needs assessment process. We also have some data from national data sets, including CDC Wonder, as well as some publicly available data through the Maryland Department of Health, as well as data from the health department's programming. It's our internal data. Next slide, please. So this slide is one that was shown during the July 9th hearing, and this slide provides an overview of the 5 different areas that make up the behavioral health ecosystem here in Baltimore. So up in the upper left-hand corner is the Mayor's Office of Overdose Response, which coordinates the activities of city agencies, chairs the Mayor's Overdose Cabinet, as well as the Restitution Advisory Board. And as my colleague Director Whaley mentioned, BC Moore also led the development of the city's overdose response strategic plan, which is currently out for public comment. In the upper right-hand box is Behavioral Health Systems Baltimore, which is our nonprofit local behavioral health authority here in Baltimore City. They manage the city's public behavioral health system and administer state and federal funding for behavioral health programming, and they are also responsible for provider accountability. I want to note that we do have members from BHSB here today who are prepared to answer questions that may come up related to the treatment providers and any oversight questions you might have. In the bottom left corner, we have our city agencies, including the health department and the fire department. So in the health department, we have a number of programs and initiatives around overdose prevention, harm reduction, and treatment. And in the fire department, they importantly operate a population health initiative, which conducts outreach and referrals to treatment. In the bottom right-hand corner, community providers. These are organizations that are independent of government. It includes community-based organizations like my colleague Candy from Baltimore Harm Reduction Coalition, as well as many others. Our community-based providers, which we've also heard from today, and our private clinics and hospitals as well. And then importantly, at the bottom, we have the state. So here in Maryland, we have a state-driven behavioral health system, and the role of the state is to set regulations, to do licensure of providers, and provide oversight and funding to providers. Next slide, please. Also, I want to note that this slide was also shown at the July 9th hearing. This slide provides an overview of the history of the opioid crisis in Baltimore City. And so we talk typically about there being 4 waves. The first wave occurred in the 1990s and was triggered by overprescribing of opioid medications and led to the first wave of the opioid crisis here in Baltimore. The second wave began in the mid-2000s, and as a result of changes to prescribing, we saw heroin use increase, which drove a second wave of the crisis. In 2013, we entered a third wave when we saw the rise of fentanyl and other synthetic opioids that drove overdose deaths. And then today we're in what is commonly referred to as the fourth wave, where we see the mixing of fentanyl with other substances, particularly other stimulants. Next slide, please. So on this slide, we have outlined some of the public health interventions and strategies here in Baltimore City related to the overdose crisis and aligned them with the 4 waves of the overdose crisis. If you look at wave number one through the 1990s through 2010, when we saw the rise in prescription opioid deaths, during this time, I want to highlight this is when the city established its syringe service program, the Baltimore City Needle Exchange, in 1994. We also saw the beginnings of drug take-back programs, changes in opioid prescribing guidelines for providers, and also in 2004, in the health department, we established our Staying Alive program, which offered naloxone education and distribution to individuals who use drugs. During the second wave between 2010 and 2016, when we began to see that rise in heroin deaths, there were additional strategies and interventions introduced, including access to naloxone for first responders, the establishment of the Prescription Drug Monitoring Program in 2014 at the state level, as well as legislation at the state level to allow for overdose fatality reviews to be established in local jurisdictions. In the third wave, beginning in 2013, with the rise of synthetic opioid deaths due to fentanyl, we saw an increase in the availability of naloxone. Importantly, this is when standing orders were first issued around the ability to distribute naloxone to the general public without a prescription. We also saw during this time the advent of test strips, including fentanyl test strips, and also the beginnings of more focus on standing up and having peer recovery specialists available to provide outreach and education to individuals who use drugs. In the fourth wave, beginning in 2016 through the present, we've continued to see an increase in public health strategies implemented here in Baltimore City and elsewhere, including the advent of mobile treatment in the health department through our Healthcare on the Spot program, the expansion of syringe services to community-based organizations like Baltimore Harm Reduction Coalition, Spark, Organization of Hope, University of Maryland, Healthcare for the Homeless, and some others. We also saw the beginnings of more flexibility in how syringe service and harm reduction services were being provided in the community, not just through mobile programs, but through the addition of backpacking and really being on the street to meet people where they are, as well as the advent of prevention programs like Kids Off Drugs, increasing access to harm reduction materials through vending machines and other public venues, as well as the beginning of being more transparent around data with the advent and launch of data dashboards. Next slide, please. So we also wanted to just highlight quickly that there are a lot of contributing factors that affect the overdose crisis here in Baltimore. This list on the slide is not meant to be the inclusive end-all list, but we did just want to name a few. At the top of the slide, we have overprescribing, the rise of fentanyl, emerging substances. These are all related to the drug supply. We also want to note the impacts of recovering from the COVID-19 pandemic, which we are still very much in the midst of. And then we also want to identify social conditions, including unmet social needs like food and housing, untreated mental health conditions, trauma, social isolation, and stigma. These are all factors that contribute to the crisis here in Baltimore. Next slide. So then I'm just going to spend a few minutes talking about some of the data trends here in Baltimore. So we can go to the next slide. So this slide shows the overdose death rate per 100,000 residents by race, sex, and year from 2018 to 2023. And we can see very clearly here on the graph that Black or African American men have the highest rate of overdose death in Baltimore City, followed by white men, and then Black or African American women, and white women. We can go to the next slide. This slide shows number of overdose deaths by age group and year from 1999 to 2023. And you can see that overdose deaths are highest among those aged 50 to 59-year-old and those 60 to 69 years of age. If you look, you can see that thank you. You can see that overdose deaths among 60 to 69-year-old residents have been increasing the fastest in recent years here in Baltimore. Also, I just want to highlight on this graph, there are some gaps in the lines. Those gaps represent when the case counts were so low that the data is suppressed, and there is a note at the top of this graph that the age group 0 to 19 is not visible due to low case counts. Next slide. So this slide shows the number of drug-related intoxication deaths by substance in year in Baltimore, looking at the years 2011 to 2023. This data comes from the Maryland Department of Health Vital Statistics Administration. I also want to point out that the Maryland Department of Health does have a publicly available dashboard that shows temporal or time trends in overdose deaths for certain substances. I do want to note that the data does not include xylazine and many other emerging substances, so we are not able to show data about emerging substances. I also want to point out that on this graph, an overdose can involve multiple substances. These counts will not add up to the total number of overdose deaths in the city each year because each of those deaths likely involves multiple substances. Next slide. Chair Conway specifically asked us about education, and so this slide shows the overdose death rate per 100,000 residents by education level and year for 2021 to 2023.
I have a quick question, if it's okay. I'm sorry to interrupt you.
Go ahead.
In the last slide, if you go back one, maybe two. Here I noted that we don't see a line for people under 20, young people. And
Yes.
I personally know of someone that has lost a child, teenager, from this. Do we have that data? Is that something that we're able to pull out?
So the data are suppressed, and the data are suppressed when the counts are 10 or lower.
Got it. All right. Thank you.
And so just going back, this slide is showing overdose death rate per 100,000 residents by education level. And just want to note that for the most recent year, there's a 19-fold difference between the highest and lowest groups. So we are seeing overdoses occurring most frequently in individuals who have less than a high school level of education. Next slide. So now we're going to talk a little bit about some of the health department's programs, and I want to again thank Candy for talking so eloquently earlier about harm reduction programs and harm reduction activities. In the health department, we have two programs that provide harm reduction services, and those are our Community Risk Reduction Services Program, or more colloquially known as the Needle Exchange Program, which has been operating since 1994. And our Healthcare on the Spot program, which is our mobile buprenorphine treatment program, which has been operating since 2018. Both of these programs provide naloxone, distribute naloxone, and they provide overdose education. in the community. The health department also provides naloxone trainings, both in the community, which we've been doing again since 2004, as well as providing trainings online and available to the community since 2016. Also, just wanted to know, again, we are one of 8 syringe service programs operating here in the city, and we're very grateful for the collaboration with our community-based partners. Next slide. So our Community Risk Reduction Services team, I just wanted to note that it's a small team of, we have fewer than 20 staff. But we are embedded in neighborhoods across the city and providing our services through mobile vans as well as street-based outreach. In addition to naloxone, we also are providing syringe services, peer support, referrals to treatment, HIV and STI testing and treatment, reproductive care, wound care, personal care kits, and other services as well. We engage with community members regularly, providing education and outreach, which includes residents, business owners, faith-based organizations, community-based organizations, community associations, et cetera. We do our very best to observe the needs of the community and work with them. And as part of that, we also do syringe litter cleanups. We are actively involved in at least 5 community-led initiatives at any given time. Next slide. I wanted to just highlight and show a few pictures of our team out in the field providing services. So this is them out doing cleanups and providing services in the community. Next slide. I want to highlight engagement with the community, which is incredibly important to the work that we do in the health department. We have maintained a consistent presence in many of the communities for more than 15 years. We've been in some of them for more than 25 years. We select the locations where we are providing services based off of the need and community input. I have seen my team spend up to a year working with a community before actually providing services on a regular basis. We, again, have conversations with the community association, with the businesses, with the residents themselves. We work with the police department and others before we go into a community. We really value community input to understand what the needs are and what services will best serve them. We also work with communities when they tell us they don't want us to be there with our vans. We work with them to find other solutions to meet the needs of people who are using drugs in those communities, and sometimes that happens through backpacking and other interventions. Next slide. So I wanted to just highlight a few data points around our naloxone distribution and education work in the health department. And so we're looking at data here, some of it going back to 2015 at the top. And between 2015 and 2023, we've distributed over 131,000 doses of naloxone, and that is just through the health department's program. Again, we have a number of partners and other organizations in the city who are ORPs who are also distributing naloxone in the community. We've trained over 40,000 people since 2015 in how to distribute naloxone. And we've distributed over 13,000 two-dose kits of naloxone just in the last 2 years of 2023 and 2024. And then I also just wanted to highlight that we did work with the city to develop a training specific for city employees that is online through Workday that launched in August of 2023. And just under 1,000 city staff have taken that online training. But in addition to that online training, we also do in-person trainings for city agencies and city staff. Next slide. Again, we just want to highlight that we are going out to provide naloxone education and distribution in high-need areas, again, responding to community requests, as well as in response to overdose spikes. We go where we're needed, and we provide this education and distribution of naloxone in a number of different settings, including street outreach, community meetings, senior centers, recovery homes, churches, universities, businesses, and more. Next slide. This is, it's not displaying, so sorry, if you could just go back. So current schedule, we did have a screenshot of the syringe exchange programs or community risk reduction services current schedule, but it's not showing up, unfortunately. I do want to just highlight that we are providing services both during traditional and non-traditional hours. We have several evenings a week where we are providing services well into the evening up until midnight. We also provide services at 2 locations over the weekend. Next slide. Again, wanted to just highlight our sustained presence in several communities. And these are some of our current sites where we're providing services. And you can see we have been in some of these locations for well over 20 years. These are areas of the city with really high need for harm reduction services. We have been to many other locations over the years, but these are some of our current sites. Next slide. So I'm going to transition now and talk a little bit about treatment access and specifically the health department's work in this area. As was mentioned earlier by Dr. Fingerhood, we do have the healthcare on the spot low barrier buprenorphine treatment program, which is a public-private partnership between the health department with the Johns Hopkins School of Medicine. The purpose of the program is to provide, again, low threshold treatment for substance use disorder. But in addition to providing treatment, we also provide a number of other infectious disease and wraparound services, including STI and HIV testing and treatment, PrEP and post-exposure prophylaxis for HIV prevention, hepatitis C testing and treatment, wound care, as well as case management services. In the last quarter, just to highlight a few things, we did test 76 people for hepatitis C and 77 individuals for HIV. We provided 79 people with naloxone training and provided buprenorphine to about 400 individuals. And since March of 2022, we have prescribed buprenorphine to over 3,800 individuals, and we've tested over 1,000 individuals for HIV and hepatitis C. So on this slide, this is a screenshot from our needs assessment, and this shows the number of spot clients who received services by the service and by quarter for Q3 2022 through Q1 of 2025. And so you can see the changes there in the number of individuals receiving naloxone training, being tested for HIV and hepatitis C, as well as those being provided buprenorphine. And you'll see a pretty impressive increase that happened around April of 2024 around the number of individuals who were being provided buprenorphine through the spot. We can attribute this to a number of changes being made in the program to truly make access to buprenorphine low barrier. And that includes some changes to our scheduling scheduling. So we're going to fewer locations, but going there more frequently, which helps people be retained in care. And we also have some stability and funding that we didn't have that's happened in the last year. So that's allowed us to fill some additional positions. And just really making adjustments to truly make it low barrier. We also started collaborating more closely with the drop-in centers, again, that Candy mentioned earlier. So Charm City Care Connection, Baltimore Harm Reduction Coalition, and others to develop relationships with those drop-in centers so that individuals know where we're going to be. They get provided services that we can't provide on the spot, and they have sort of more of a health home or a health hub where they can go to get services, and they're not just relying on the van being out there. Next slide. Just showing you, this is our current schedule here and map of the locations where the spot van is out in the community providing services. I also want to highlight something that we have been expanding over the last year is the Bupe telemedicine line. We do see about 20% of our patient encounters for buprenorphine are coming through the telemedicine line. Next slide. This is again just showing some pictures of the SPOT team out in the community in action providing services to residents. Next slide. So this slide shows mental health and substance use licensed and certified providers and programs in Baltimore City. Again, this map can be found in the needs assessment on our dashboard online. I want to again reiterate that we do have Baltimore Health Systems Behavioral Health Systems Baltimore here with us today to answer questions you might have about treatment providers, but wanted to just show that there are a wide number of providers across the city. If you look here, green dots are mental health providers, red dots are substance use disorder providers, and purple are providers that provide both mental health and substance use disorder services. Next slide. We also want to acknowledge that there are many primary care and other mental health care providers in Baltimore City, and note that we actually have more mental health providers and primary care doctors per person than in Maryland and in the US overall. But having a lot of providers doesn't mean that it's good quality care that is being provided to individuals. And we know that quality of care is something that remains important for us all to be focused on and addressing. Next slide. And then I just also wanted to highlight a few key takeaways that were noted in the city's overdose needs assessment around treatment. So barriers to accessing medication for opioid use disorder include stigma, lack of knowledge of available resources, and transportation. Again, we know that quality of treatment can be improved. When we were engaging in our interviews and focus groups, many community members noted poor conditions as well as rigid program guidelines being barriers to care. And also there were gaps in social support services that were noted that leave many without the resources to continue their care. And importantly, 49% of our respondents identified smoother transitions between residential and outpatient treatment as a critical need to be addressed in Baltimore. And then I just also want to highlight and bring it back to the draft strategic plan. Both access to treatment and the quality of treatment are priorities in the draft strategic plan that is currently out for public comment. And thank you.
Thank you.
And I believe I will turn it over to the fire department.
Chief
and
Matz.
Chief Matz.
Chairman Conway, Council President Cohen, ladies and gentlemen of the City Council, good afternoon. For the record, my name is James Matz. I'm the Assistant Chief of EMS for the Fire Department. I also oversee fire communications and 911. What I wanted to do today was just go over a couple things. Chairman, I only have 300 slides. We'll be fine, okay?
That's no
Honestly,
surprise.
it's only 8, and 3 of them are some that I used with Councilwoman Porter, but I updated the numbers for you. So I promise it'll be quick. I talk fast and I'm loud. I don't need a microphone, but I'll go with it anyway. Real quick, before we talk about population health, just go back one for me real quick. What I wanted to do is just give a scene setter for everybody with the population health. Population health really came about in fiscal year 23, in calendar year 2022. Look, the primary mission of the fire department is respond to basic and advanced life support emergencies day in and day out. Part of those emergencies are people suffering from substance use disorder as well as overdoses. One of those things is thanks to some funding from the supplemental payment program, Mayor Scott was able to fund the population health initiative. So in, and you can go with the next slide if you'd like. Actually in calendar year 2022, FY23, we're actually able to stand up the population health unit. During the actual initial implementation phase, we focused on 3 main areas. Those main areas are suspected opioid and substance use, high utilizers, because a lot of times those high utilizers, like they talked about earlier, are the trifecta of mental health, homelessness, as well as substance use disorder. So we address those as well as population health awareness events. And the goal of the population health unit was really to expand the role of pre-hospital providers. What does that mean? That's where we're trying to take medicine into the street. The fire department's lucky. We're welcomed into a lot of situations on people's worst day of their lives. Those relationships do carry over. Part of the mission with the population health unit was to be able to establish relationships with people on the street. Why? Because when those people are ready to take the next step into treatment, we're there to bridge that gap. So that was one of the main things. We also want to decrease overutilization in 911 for low acuity or low priority calls. Promote transport to alternate destinations like urgent care, FQHCs, things like that. And then provide that link to resources and treatment. One of those links that Deputy Commissioner Martin just brought up was a spot fan. It's one of the ones we work very closely with. I'm happy to report we've had a lot of success with the population health unit. As you can see from just some of the numbers, we're able to have direct patient contact with 635 people, and then we were actually able to reach out to another 16,600 people. Why? The way the protocol is kind of law for EMS providers. It requires us, in order to leave behind Narcan or to outreach, we have to be brought to those neighborhoods. How? For suspected overdoses. So what happens is our crews go out to those calls. What we're able to do is to actually meet those individual patients suffering from substance use disorders, but we're able to outreach to family, friends, bystanders, and to get bigger bang for our buck. Go ahead, next slide. Thanks. Some of the things that we were actually able to do through July 18th of this data, we actually were able to do, remember I told you we do those public health awareness events? There was over 2,300 events where we actually do one-on-one education with the public. In addition to giving out and doing the substance use disorder and overdose prevention training, we're also doing leave behind Narcan. We're also, in almost 1,300 instances, leaving fentanyl test strips behind, over 1,300 strips with the xylazine test strips. And then we use outside program referrals just about 900 times. The other thing that really kind of shocked me initially with the program is you got to understand the program, anything that I start, there's always a mistake somewhere. I didn't realize the amount of other services that we were actually able to outreach. We actually had roughly 12,000 incidences of where we're leaving behind food, water, clean needles, as well as wound care kits. People that suffer from substance use disorder have terrible wounds, and we're able to link that and bridge that. And then long care treatment, that's the long-term treatment. We're able to actually get 23 people in a long-term treatment. We do track them to see how they're making out with that treatment. So I think that's a success. Next slide, please. And this is one of the models for the state of Maryland in terms of pre-hospital. To date, we've actually been able to leave over 16,000 kits or 33,000 doses of Narcan behind in the public. Where do we see that? When we were at Pennsylvania North Avenue, our kits were there. We saw our kits there as well. Next slide, please. Chairman Conway, you had asked for some data, and that's what I'm going to provide now. This is the data, people. I had to give you the definitions. There's two kinds of overdoses that we're going to be talking about today. There's the opioid overdoses, where we legitimately give naloxone or Narcan, and we're looking for a response to that. Why? Because naloxone only works on one thing, which is that opioid. The other thing that they do is they do like a data search in our reports, and if they find the word Narcan or a 23 card, which is a dispatch determinant for an overdose, they're flagging that as well. Next slide, please. So what we were doing is we actually sat down and we were taking a look at the total number of overdose calls that we've had, and that's overdose as well as repeat overdose calls. As you can see from the numbers, we had about 1,600 reported overdose incidents in 2023. That number climbed to 24, almost 2,500 in 2024. And in 2025, that number's down to 887. Repeat offenders, which you're gonna find if you look at year-over-year numbers, it's roughly about 10% of those people are repeat offenders that we're finding. Next slide, please. This is the overdose calls by time frame. Just a rule of thumb, our peak with overdoses is roughly 9 in the morning till 9 at night. The absolute peak over this 2 fiscal year period is 12 o'clock noon. One of the interesting things we found with like North and Pennsylvania, those start right about 9 o'clock in the morning. It seems to be that time of the day that we're starting to see. Next slide. And then this is the EMS administration in Narcan. In 2023, we had 1,600 instances. In 2024, there was 24, and then in 2025, there was 887. Next slide. Disposition. So what does this mean? This is how do we clear these calls? Of the roughly 3,700 calls we had over this 2 to 3 year period, roughly 50% of those calls result in refusals or refusal of care, refusal of treatment. The other half will go to the hospital. Why? That's where that population health unit is out there being able to outreach to those people. They have to be willing and ready for that treatment, and that's what we're there to do. Next slide. Average response time you're going to find over the whole 3 years, roughly 3 years, it's running right about 7.5 minutes, which is pretty par for the course for that. Next slide. This is total number of 911 calls related to overdoses. I got to read this because they added a whole bunch of stuff in here. It's not just Narcan administration, but suspected Narcan is found in the report. There's also a primary impression of overdose as well as a 23 card. That's the dispatch determinant that they use when they dispatch calls. It's a 23 card. It'll be like a 23 something. One of the things that's interesting about overdoses, it's kind of a science. No call usually comes out as an overdose. It usually comes out as a man down, woman down, altered level of consciousness, trouble breathing, unknown, something to that effect. So it's kind of a science. It was one of the things that we had to do when we were looking at some of the calls from Pennsylvania and North Avenue. Next slide. And then this is kind of what we were talking about earlier, is the number of distributed kits. There was over 3,000 kits in 2023. 24, we had 9,500, and then in 2025, another 3,100 kits. And then last slide for me. What we did is over that 2 fiscal year period, we actually did a plot map to show where they have. What you're going to find is there's going to be clusters in areas you would expect. You're going to see some in Park Heights. You're going to see up Pennsylvania across North Avenue. You're going to see that southwest Baltimore side. And then you're going to see a cluster over in the east side like Madison. Other than that, that's it for me unless I have any questions. At this time, I will pass it over to the Deputy Commissioner, Kevin Jones.
Good afternoon, Council Chair Conway, Vice Chair Blanchard, Councilman Glover, Porter, Gray, Deputy Commissioner Kevin Jones, Operations. You know, Baltimore has continued to grapple with the devastating impact of opioid overdose. From January 2024 through July 14th of this year, the Baltimore Police Department has documented over 2,000 overdose incidents, with 700 plus being fatalities and 1,600 non-fatal overdoses. Councilman Conway, I know we have provided you with all the requested documents from our agency. What we do know is the Western District, Northwest, and Eastern Districts consistently report the highest volume of cases, highlighting localized hotspots and opioid activity. In 2024, BPD administered 490 Narcan doses across 258 incidents. So far in 25, 161 doses have been administered in 90 incidents, indicating ongoing need and life-saving interventions, for life-saving interventions. Demographic analysis shows that the majority of overdose victims for right now are Black males aged 31 to 60, as the deputy chief had said, with a growing concentration in the 51 to 60 age range. BPD's Police Policy 801 ensures that officers' response to overdose is with a health-first approach grounded in Maryland's Good Samaritan law, which discourages enforcement action against those seeking medical aid. Through cross-agency working groups, public health collaborations, and targeted initiatives like the Lexington Market Project, BPD aims to address not only overdose events, but also those root causes, focusing on prevention, treatment access, and harm reduction. I will say for this agency, we have over 1,800 sworn members. Each of those members within their person have 2 4-milligram doses of Narcan on them. The recent Penn and North incident highlighted a focus that we've had, spearheading a lot of co-production in that area in reference to the new face of what collaboration looks like in reference to this epidemic. I will now pass it on to my team.
Arnold Jenkins, Major for the Baltimore Police Department Youth and Community Partnerships Division.
If you could speak into the microphone, just so we can hear you. It's a little hard to hear.
Thank you, sir. Major Arnold Jenkins for the Youth and Community Partnerships Division, Baltimore Police Department. So we're going to touch on this slide here, starting with the collaboration between us and the fire department. So frequently at commanders meetings, we've reached out to the fire department also to offer Narcan, naloxone, and also CPR seminar, not a full certification course, but something that allows people to familiarize themselves with how easy it is to use. I've personally used Narcan multiple times on someone in order to save them from an overdose. It actually works very quickly. It's very easy to administer right through the nostril, very limited wait time, and highly effective in a short period of time. So we want people to be able to see the effect, how important it is, but also to be able to easily pick it up and use it as quickly as possible. So that's a part of why we do that. Working with the Operation Pulse Group too. So this is focused on creating a united, resilient environment. This is a combination of Johns Hopkins working with local faith leaders actually, trying to make sure that we're just doing better ultimately for the community overall. So their organization has actually hosted drug takebacks. Beyond that as well, BPD has also hosted drug takebacks with the DEA also at a number of locations. And then I listed people encouraging people on here because previously years ago, when I was a trainee, we actually went to this organization. We got to talk to people about mental health and crisis and also addiction as well. And it's something that's impactful on me to this day. Now that being said, if we look at the Baltimore City Needle Exchange, we've heard about that in depth. We actually were able to participate in backpacking recently. So on July 17th, we actually went out with Dana Young from the health department, got in touch with the director of community risk reduction services, Jeffrey Long. We went out there to Penn North recently, ended up meeting people exactly as they said, where they are, trying to make sure that we were out there. So what were they offering? Naloxone, which they were able to get to people out there. Also water, hygiene kits as well at the same time too. So I just want to also point out that as the heat gets worse, dehydration and the heat can actually worsen the effects of an overdose. So the health department had cold bottles of water out there. So we do plan to continue to do that, to go out again. Just looking at some of the effects too, overall. We touched on the working group a bit, but I'm going to mention a little bit more in depth too. Out of the recent overdoses at Penn North, our officers are out there administering naloxone in at least 10 different cases. So these are first responders getting out there, being able to be on scene as quickly as possible, being able to administer it quickly. Looking at the working groups in particular, just looking at that, we currently have an iteration in Lexington Market. So that's our newest iteration, led by Monty and BPD. So Lydia Sonny Schnitzer is currently one of the project managers on that. We also have communication with the executive director of overdose response. And then recently as well, we actually are doing Blitz. So our Blitz will be tomorrow over in Penn North. And then additionally, looking at a prior Blitz too, you have on that previous slide, we didn't get to talk about it. You also had beyond that as well, a focus on the Southern District too. So there was actually a Curtis Bay enforcement action that was taken. And so part of what we were doing as part of the working group was to make sure that we were providing a body of services for stabilization, to include working with local recovery groups as well. So they were identifying different needs to include looking at community identified locations and also 911 calls. Additionally, beyond that, the working groups can also consist of public health, outreach and engagement, place-based services, and of course also enforcement. So while GVRS is not a part of the working group, it did coincide with the actual location for the working group in the Southern, which is why I just wanted to bring that to your attention. But that's all I have.
Awesome. Thank you. Those are all the presentations?
Yes, we're here for answering questions. Also, Colonel Velte's here because I know you had some questions on sort of the enforcement side of things, although I know this is health-based, which is really what we're discussing.
Yeah, I really appreciate you guys. And also appreciate the preparedness for the hearing. I understand folks in BPD leadership, you guys do have to leave at some point. When you need to step out, feel free to do so. I want to sort of couch this conversation so everyone sort of understands, at the very least, I'm going to open up to questions from the committee. So for those that have questions, please let me know. Before doing so, I want to help people understand at least how I see this issue and why I believe all the people here is probably still not enough for the people who need to be at the table. But we only have so much time today and it's been 2 hours already. So, so first, our harm reduction folks are, I think, critical to meeting people where they are and dealing with their addiction. I believe our health department is key towards understanding the long-term impacts and how we got to where we are. They've been working on this stuff at a very, very high level for decades now. And so their expertise and broad understanding is going to be integral toward any progress going forward. Our harm reduction folks are on the ground. They're seeing this work firsthand. Our police department is often getting all the complaints and trying to figure out how to untangle our drug markets and our open air drug markets across the city. Our fire department, our EMS folks are our first responders. Every time we get a call for someone that has overdosed or has unfortunately passed, those are the folks that are there. But also with the population health team, which I've had the fortunate opportunity to do a ride along with, we are not only responding to issues, but organically and methodically building relationships in the communities that need us most and are dealing with this crisis at the highest levels. So I'm really, really proud of the work that you guys are doing. I think we need to figure out how to do more and work across silos in order to get there. Our folks at Hopkins, major hospital that is going to be receiving a lot of the folks that are dealing with these issues if we're transporting them, but also they're thinking big about how we can solve these problems. Hopkins is advising many cities across the country on how to look at exactly this issue. And so I'm really, really fortunate to have you guys as experts sitting in front of me, probably live 15 minutes away from here, that we can continue to rely on. So I really appreciate you guys being here. We don't have Monty here at the table. I will take a fault for that. I should have made sure I put them in the LO, but I would say going forward, I think they're going to be integral towards figuring out how we, in our open air drug markets, get to those young men and women who are dealing drugs and systematically dismantle those open air drug markets in a way that is effective and thoughtful, much in the same way that we attack violence across the city. We don't have housing here. Housing is going to be really important toward a community development strategy as we think about what we do once we have dismantled or while we are dismantling our open air drug markets. How do we support those businesses? How do we get more people to move into those neighborhoods? How do we encourage productive activity so that every time someone who is dealing with addiction or in recovery, they're not necessarily as triggered by the environment that they have to walk through every day. But these are the things that, at least in my limited capacity, I think need to happen. And many of you guys are here, and I hope the rest are watching this hearing. But I want everybody to understand why it's important that we understand how we got here. I really appreciate you, Deputy Commissioner Martin, for providing that long-term perspective on how we progress from the 80s to 2025 on this issue. Because I think if we don't know where we're coming from, we'll never figure out where to go next. So I just want to, before we get into questions, I want everybody to understand at least how I see it. That doesn't mean it's right. I'm no expert, but there are a lot of experts in the room that can help us all wrap our head around where we fit respectively in this problem-solving issue. So to that question, I'm going to ask. I'm going to allow folks 2 questions before we go around for our next round. But my first question is actually to the police department. Unfortunately, Monty's not here. One of the things we'd requested in the Public Safety Committee at the end of last year was some sort of approach to open-air drug markets, and that continues to be, I think, a challenge for the city. Can you tell me where we are with that effort?
Good afternoon. Colonel Velty, I oversee the Crime Strategies and Intelligence Division. Open-air drug markets, obviously extremely important to law enforcement, important to the overdose situation we're experiencing. We're starting to concentrate more on dismantling the street-level drug organizations that are selling some of the stuff that's causing the overdoses. I think the focus, specifically for GVRS, obviously, is the shootings and homicides, but the two are not exclusively, mutually exclusive on many fronts. We referenced the takedown in the Southern District. We saw a violence-driving group that transplanted from the Western into the Southern, but we also saw an overlay of a high amount of overdoses within that DTO. That particular DTO was targeted for extraction. So I think some of the things we're trying to do is learn some of the lessons from the focused and targeting that we do towards the violence and apply it towards the DTOs that are driving some of the overdoses specifically, help translate some of that intelligence for action in the district action teams, as well as the post officers in patrol for the narcotics enforcement and the dismantling of those organizations.
I'm going to make this an official follow-up for the committee. I don't know how much time you need. We're here. I think we have this issue. It's not going to go away without a concerted effort. And I don't put this squarely on the police department. I want to be crystal clear. This is why I missed an opportunity to invite Monty to this hearing. But I think they are also very important toward untangling this issue. So how much time do we need for us to pull together some sort of strategy, something to be clear about how we want to address this issue?
So obviously you and I have had this conversation many times. And I know we can all appreciate the intricacies that are solving a problem that is, quite frankly, as old as, I'm pretty old and way before I was born. So I think, I don't know exactly a time frame because I know we do have to talk about it. I know what you're looking for and we've talked about it. It's almost like GVRS for drugs, right? So, but I think we're also going to see, like Colonel Velty said, as GVRS expands across the city, I think that's also going to have a great effect. We just expanded to the Southern. So I can't give you a specific time frame because I know we need to work with the mayor's office to coordinate because I think it has to be more than, like we said, right? Because unfortunately to dismantle, we have to be careful that we wouldn't want to be further victimizing the people that we are trying to help. So I think we all have to be really cognizant of that. So I can't give you a specific time frame, but I know what you're looking for, and I promise you it is not lost on BPD that it has to be like a global strategy. So I can work with the mayor's office and get you a more specific time because I know you did ask us about that in the past.
So for me, and thank you, Aaron. So for the agency, I I don't want any of the council people to leave here thinking that there is not a strategy within BPD. So whether it is at PoliceStat or CompStat or our daily crime calls, sometimes to my own detriment, the push is in reference to visibility, proactivity, and engagement. My biggest concern is holding all individuals, no matter where they are in BPD, accountable for their specific post and area. So what I don't want to have is, and a conversation that I have with Colonel Velty all of the time is, I don't want district commanders to always be focused on looking at GVRS and anti-crime section as a relief to something that should be done by a district commander all the way down to the post offices. What I demand, I've been here a long time, I've got 31 years in this, I'm old, right? Is when an officer leaves the station on his shift, he needs to know whether he's going to be making a right, or she needs to be making a right or left, right? Where are they going? What are they trying to prioritize? Within every district, there are probably 7 drug organizations that they, or 5 or 6, whatever it may be, some less, that they know they need to physically have a touch with. That touch may look different from many different officers. I was a drug and a gun officer. I was operations. I was plain clothes like Velty. I was wearing wires. That was my thing, right? That's not every cop, nor should it be. There are some officers who it's just not their thing. So there has to be a realization, if it's not your thing though, there still is a level of disruption that has to happen. Pulling up, getting out of your car, disrupting it, right? There also has to be a level of cooperation between those of us who are operationally centered and those who may not be. So I may have a conversation with Aaron because Aaron does traffic, or Aaron is a good investigator, or Aaron does something else. And I say, look, I don't like to do traffic, right? It's not my thing. Give me some love in my areas where I'm having traffic calming issues, and I'll come over to your post and I'll give you some love on your drug corners. It has to be that collaboration. There's a level of expecting every officer to have some kind of input, whether it is criminal citations, whether it is engagement and visibility. There is all the way, that is all the way up to the anti-crime section. Every officer has a piece of this puzzle in reference to dealing with those open-air drug markets.
So I appreciate that, Deputy Commissioner. And all you're saying is 100% true. I think what I realize, and I'm going to keep repeating this because it's very important, is you guys don't have the locus of control over everything. I would suggest, much like the health department doesn't have the locus of control over everything for opioids, you don't have control over everything having to do with open air drug markets. Certainly you have the ability to enforce, certainly you have the ability to put officers on the scene, but what you can't do is change the environment. What you can't do is necessarily offer resources and jobs and opportunities to the young men on those corners. And this is where I think you need a comprehensive approach to open air drug markets. So I think this is where MONSE would be important. And once again, my fault for not inviting them to this meeting, but I do think they are key in this effort. I also think that HCD, key in this effort, efforts to support businesses in our major business corridors that aren't able to do well, in part because they have drug dealing happening in front of their stores. Now, you guys certainly have an important role, and maybe even a lead role in this effort. But there are certain things that an officer or even the police department can't do. And this is why I'm asking the question this way. I want you to appreciate that there needs to be a comprehensive approach here. And so not to pick on the police department, you guys have been doing a phenomenal job. I think the challenges are changing, and we're now seeing 3x the number of people, and we have been, frankly, for years, 3 times the number of people dying from opioid overdoses than are dying from homicides. And that's in part because of the great work you guys have been doing. That stat sounds as crazy as it is. So what I want is for us to think about all those pieces, think about how we don't criminalize people for dealing with addiction, and figure out some way to strategically dismantle open air drug markets. And I'm not asking for a perfect plan. I'm asking to start somewhere and we can iterate. Yeah, appreciate it. My second question, Mr. McDermott brought up interesting point about COVID and its impact on the health department's ability to and focus on this issue. Deputy Commissioner, can you speak at all about what changes we made during COVID to address the opioid approach?
Thank you, Chair. I just want to make sure I answer the question that you're
Sure.
asking. So are you asking what were changes that were made during COVID as it relates to overdose?
So Mr. McDermott, I think, brought up that double the people were dying from overdoses during the peak of the pandemic than were dying from COVID, which was interesting to me. But then that COVID was still the top priority for the health department, which, to be fair, does not surprise me. But I'm curious what changes we then had to make in order to respond to COVID. Are there programs that?
Yeah. So I think first I want to highlight that actually in the health department, both our syringe exchange program and the healthcare on the spot continued operating all through the pandemic. And that was not the case for all of the harm reduction organizations and providers. So we did prioritize continuing to provide services, and we actually, for our community risk reduction services program, ended up doing more than what we normally do during the pandemic. I want to say that there were a lot of efforts, both at the state level and the city level, around certainly during the days of stay-at-home orders and sort of like the shutting down of society, where there were a lot of exceptions in rules around take-home medication for individuals in substance use treatment, and the changes around telemedicine and other things to help continue providing services to individuals. We worked really closely with Behavioral Health Systems Baltimore on ensuring that naloxone was available to individuals in treatment programs, and worked with treatment programs to provide naloxone to them, along with COVID test kits and other things. So there were a lot of efforts around ensuring access to care that were underway, as well as continuing to provide services. I appreciate Mr. McDermott's perspective and comments that he made earlier. But I don't agree with all of what he said. Overdose was still something we were very much aware of and working with our partners to address within the context of COVID.
Thank you. I appreciate that. I think this is an important opportunity for us to learn. God forbid we have another pandemic that takes away critical resources or the attention of the city from something like this again. Hopefully we never have an opioid epidemic again. Hopefully we are truly able to resolve this issue. But I think it's important for us to understand if we have not asked ourselves what impact, and it seems we have. You guys detailed this in your presentation. But I think it's important for us to learn about what tweaks and changes we did make in order to understand if we were presented with these options for any other public health issue in the future that critically pulled on the health department's attention, that we know how it affects how we respond. And, you know, I think, you know, looking back, hindsight is 20/20. And I think there's still a lot that we don't know about. I don't know about the decisions that we made during that period. But I would say certainly I know the city's focus was probably 98% on not opioids, on COVID. We were all scared during that time. I do understand that. The question is, could we have done anything differently so that we at least kept critical programs like the opioid programs running successfully?
Yeah, I appreciate that. There's actually a name for that in public health preparedness, which is called having an after-action review. And of course, for a multi-year event like COVID, there's a lot to review and digest and talk about. I don't want to minimize what's been raised here today as it relates to overdose, but I want to say there are a number of public health areas that were put on the back burner, so to speak, during the height of COVID, and public health is still recovering in a number of areas, not just overdose. But I appreciate exactly what you're raising, and agree there are lessons learned that we need to implement moving forward when it comes to emerging events like COVID.
Yeah, if you guys aren't already considering, I would encourage you to do that. I think it could be instructive for the future of the city, should we ever come across something like this, to do an after-action report looking at how COVID impacted other programs, and especially this one. I think it's something to be learned there. I'm going to hand off to my vice chair, Councilman Blanchard.
Thank you very much, Mr. Chair. A couple things, and I might dip back to the nonprofits as well. But I think Sapinas is left already, so maybe Justin, if you could make the connection. I was really interested to hear this thought about innovative policing techniques to walk the very fine line between ignoring, drug use and something more akin to a war on drugs type approach. And I'm really interested to to dig in on that. So I'll follow up with you on that one. The other question that I had for our representative from the Baltimore Harm Reduction Coalition, the line about the safe syringe program, the SSP. So you said it was 5 times more likely to enter treatment and 3 times more likely to stop using. I'm really interested in that. Can you talk through, and I know it's relationship based and there's a couple things going on, but just talk me through how this program would be effective at helping people, in their addiction or get past it.
Heard, I can do that. 2 things. First thing, thank you for the question. Second thing, there are like 3 or 4 things. I wanted to name Chair Mark Conway, that I know that you were specifically talking to health department and all the stuff that they were doing. I want to name that during COVID, at the very beginning of COVID, our outreach, over quadrupled during that span of time, because there were people that were going down at different points in time. And so that is when our outreach, it just went so far, and we had volunteers using their personal cars to drive around to neighborhoods that we had been in occasionally, but needed more service because people were out. And so I just wanted to name that as we were also trying to stem the tide of the shenanigans that was COVID. So there's that. That's not me, hooray. And to answer your question, so yeah, community is always helpful, right? Community, having relationships with people, but it's also the referrals and the access to care, and being able to have supplies that are new. It's all of these things put together give people the opportunity to think about their drug use and what it looks like to continue or what it looks like to stop, right? Like, we keep naming housing as something that we keep naming housing as something that needs to be at the table, and it does, right? If I'm looking for a syringe, if I'm looking for any of those things, if I'm worried if I'm pregnant, if I don't have housing, like if I don't have all those things, my drug use is honestly like the last thing that I'm thinking about, right? Especially if I'm homeless or if I'm doing any of those things. So it gives people the opportunity to get the stuff that they need, get some referrals, have that human touch, and make different decisions. There's also options, right? Whenever you have those whenever you have the relationships with community, you have the option to have conversations about like what it looks like to go into treatment. If there are people on staff that are in treatment or have gone through treatment or are in like 12-step programs, it also gives them that opportunity as well. And also being a member of the syringe service program and having your identification, there's like, we give out cards and so does all the other ones. Having that on you whenever you're carrying supplies means that if you were stopped by a cop, police officer, and you produce that, you're not supposed to be picked up, right? And so whenever people are able to carry supplies and feel safe doing so, we would like to decriminalize paraphernalia, but whenever they're able to feel safer carrying those supplies also, it's like, again, they're using new supplies, they're able to get those supplies, make those connections. Does that answer your question?
Yeah.
Okay, cool.
Yeah, no, I think you're able to have a lot of conversations that you wouldn't necessarily be able to have outside of that environment and make those connections and get to those resources. That's really helpful. Two just brief thoughts. One, really happy to hear about the Lexington Market collaboration. Was texting Aaron and looking forward to attending that one next Wednesday. Obviously, it's a very real impact on the humans involved. It's also a very real impact on the neighborhood. So I think that's incredibly important. And the last point, this is something I think I brought up at a couple hearings, but this drop that we're seeing in the very substantial drop that we saw last year and into this year. And I know I've talked with both health and I think Assistant Chief Metz about this as well. But getting our heads around why this is happening, because I just get nervous when something really good is happening and we don't actually have a clear, logical, an understanding of the mechanisms of it. Because how do we make sure it's going to keep going and not regress and whatnot? So I know, had the opportunity to talk to health, and I know health did some digging into this. I don't know if maybe this is kind of more for the mayor's office, but it's just something that if we don't understand it, how do we make sure it keeps going? And so just an important thought to keep driving home there. So, Mr. Chair.
Thank you, Councilman Blanchard. President Cohen.
Thank you, Mr. Chair. Thank you to all the partners here. I want to thank both Chair Porter from the Health Committee as well as Chair Conway from Public Safety Committee for the series of hearings that we are having on this issue. It is among the most pressing that the city faces, and seeing the City Council this engaged across different committees is extremely heartening. And I also want to just thank all the partners, harm reduction, health department, police, mayor's office, BHSB, everybody's here today. I want to just make two comments and a quick question. Comment number one, and I said this yesterday to the mayor's nominee, Dr. Taylor, to be our next health commissioner, is that I do believe there is a profound need to rebuild behavioral health within our health department. I think that extraordinary work was done during the COVID pandemic, and I am extremely grateful to the many people that helped to keep folks alive from a transmission and spreading the virus perspective. And I think pre and during and post the pandemic, we have seen atrophy within our behavioral health systems within the city of Baltimore. I personally believe that we shop out and farm out too much work. While I am deeply respectful of all of our nonprofit partners in the space, I think that our own health department, which is, I put our health department against anyone else's in the country. That has always been one of Baltimore's great shining strengths. But I think we have a long way to go toward building a truly robust behavioral health department within health. That was comment number one. Number two, just a quick story. In 2020, the city passed legislation, the Healing City Act, that made us the first to address trauma through legislation in the country. We've worked closely with the health department and others on its implementation. One of the things that first agency we trained in trauma-informed care was the library system, and we spent about a year doing a deep dive with the librarians. At the end of it, Heidi Daniel, who was our head librarian at the time, said, hey, look, from a policy perspective, the issue that I am most concerned about is substance misuse and folks in the library, this being a safe place for them to come, but some of the tension that exists with patrons. And our current policy is zero tolerance, and it is to write people up and kick them out. And I know, having now gone through a year worth of trauma-informed training, that is an inappropriate response to a public health issue, to an addiction issue. And instead of just getting rid of that policy, I would love to be able to bring something back into the library that could support people and make it clear that we're not looking to have folks use drugs in a library or get drunk or get high, but we need some way to be able to address this. And so we started the Peer Navigators, started at Penn North, and it started with just like 2 peers, and it grew and it grew and it grew. Care First gave us a big grant. Most recently, the city solicitor was able to bring back $5 million to support the peer program. But it's really good and it's working, and it is, in my opinion, a really strong way to support both sort of a harm reduction approach and a help folks get into treatment approach. And I just want to advocate for that model, because I think Baltimore, having peers in libraries, having soon to be peers in other spaces, has been a real add for our city. And I think the more we can connect BPD, EMS, EMT, fire, like have peers stand in that space, folks who have had experience, lived experience with addiction, I think is critically important. And last thing for a question for the health department is, I'll just say this is one of those issues that touches, Councilman Glover spoke about, it touches so many of our families, every single person in the city of Baltimore. I would guess most people in the United States of America have had a family member that has been impacted by this disease. And so it is one of these things which is hyper-located in disinvested communities and simultaneously touches everyone. And I think we've come a long way in our thinking about it, but we still have a long, long way to go. And, I share Councilman Glover and many other folks' frustration as we continue to see our neighbors get sick and die. This is to the health department. My question for you all, as we think about this next iteration, new health commissioner, new funding from the lawsuits with the pharmaceutical companies, can you talk about what it looks like to build internal infrastructure, and I've had this conversation with Director Whaley as well, to be able to address this issue? You talked earlier in your slide about trauma. We've talked about needing to refresh and re-up our crisis response mechanisms. Can you talk a little bit about what it looks like to rebuild this muscle within the health department? And not to, we got to be partners with everybody, but to build our own infrastructure versus relying so deeply on partners.
Thank you, Council President. So in the health department, we have worked on an infrastructure plan for the funding that is coming to the health department from the restitution fund, as you know. And as part of that, we are building up our team internally around behavioral health, which includes some of our existing work and expanding it. We also have been having conversation with the mayor's office around existing work that is happening in the city as it relates to the consent decree and activities underway there, and how to make sure that we are having a collective one voice sort of effort in these activities, because there is a lot of work happening in different spaces, and making sure that work is coordinated, I think, is key.
And I would just hone in on that point, which is, in my estimation, there is a lot of siloization that's happening in a bunch of different spaces, and like lack of sort of clear outcomes data, lack of accountability for some of our partners in the space. I think that we need to do more to be that central aggregator and to like make clear that, you know, these are the outcomes that we're looking for, and to drive toward those outcomes, particularly for a city like Baltimore, which again has been ground zero for the opioid crisis, has been ground zero for many of these profound behavioral health issues, and has been the place of innovation in the public health space for a very, very long time, and has some of the best hospitals in the world and some of the best public health institutions. And so I think really there is like a really strong need for you all to be that central aggregator and node, and to rebuild that muscle. And I know this is a council, and again, truly grateful to Chairwoman Porter for her leadership that is very eager to support in the rebuilding of public health muscle memory. Yeah, sorry for interrupting.
No, I appreciate that so much, Council President. So, yeah, as I said, we've been having conversations, we've been working really closely with Director Whaley, as well as having conversations with Behavioral Health Systems Baltimore around, you know, how we can get collaborating and coordinating together to be, as I said, sort of in that one voice approach. And I think to your point, one of the strengths of the health department is our ability to be a convener and a facilitator across the public health and the healthcare system. And so that's where I really see the health department's role in bringing all of these entities together, along with Director Whaley.
I appreciate that, and I'm gonna stop talking and pass to my colleagues. I will just say it has felt at times really chaotic and unclear. When I've sought data, do I go to BHSB? Do I go to the health department? I think that in part because of how, particularly around overdose and some of the lag in reporting and when data gets produced, I just think there is a strong need to rebuild and build some real strength and infrastructure in the health department. And again, I appreciate the work that has been done. Obviously, we're a city that is hurting from this disease. And again, appreciate the convening that's gone on. And I thank you, and thank you, Mr. Chair.
Thank you, Mr. President. Councilman Glover.
Thanks, Mr. Chair. My question is to BPD. Like, what, you guys, again, to piggyback off, like, the chairman, we've done some great work with reducing crime in the city. I mean, especially, like, again, East Baltimore. Like, and we have really worked with Southeast, Eastern District, and you personally, like, I've seen the drop from the partnerships and things of that nature. I think the problem that I receive a lot from constituents is that it is like the open drug, air market that we do have in the McElroy Park community. And when it gets to a point where the community themselves can't even like open the back door to, grill in their backyard because of the homeless encampment that we have in the back due to the, the drug use of many of them that come into our community. My question is, how do we get the police department to kind of step in, because they're doing it right there. Like, it's like clear as day. Like, even me doing, video footage up there and even having the media there at one particular time, nobody's moving. And when you hear, again, like, what are the reasons are you coming here? Why is it so easy for you to purchase here? It's because it's easy because the dealer is just, selling it to them right then and there. What do we do to change that narrative? Like, what can we do?
So I hear your frustration. You like growing up on the east side, not having or having family members who have dealt with not only the destruction of open air drug markets, but then the substance abuse disorder issues, having family members, myself and friends die. I will say that it's multifaceted. So I will say for individuals who are living in those areas that unfortunately are being plagued with these open air drug markets, we still need the calls for service in reference to what's going on. We still need the calls to Crime Stoppers in reference to specific information that we work on. What I expect is, as I said before to Councilman Conway, is that officers get out the car and engage. And that engagement may disrupt it for that moment. And they may come back. We are monitoring in BPD, and one of our CompStat metrics is, a level of engagement of 10 to 15 minutes getting out of their car to disrupt it. Anything less is not effective, anything more is not effective. So that's the sweet spot. And then they do that in different intervals to continue to disrupt it. Mm-hmm. What I will also say is unfortunate, and I'm not making any excuses because I still have family members who live here and give me the same things, is if there is an ongoing investigation, and I won't go into that, but sometimes the response to that you won't see in that immediate area.
Gotcha.
Because we have to do things outside of that area in reference to either someone who was buying or dealing or whatever. So you may not see the immediate impact. Mm-hmm. Is that to say that every area has responses? I'm not even going to say that either, right? What I will say is post the incident on July 10th at Penn and North, a response from me to my data-driven strategies team was, I need you to highlight the top 5 calls for service for open air drug markets. And what I want to see is what is the district's response in reference to proactivity, engagement, and arrest, right? Because if something is here for calls for service, but then there is not a productivity response that is adequate, then there's disproportionately something wrong going on. So what I will say is to your constituents is I don't want them to be hardened or not calling because they don't think something is being done. I need that data. Mm-hmm. Because if it's going on and it's underreported or not being reported, then I'm going to go to Penn and North because the data says that the density map is where I need to be. Mm. But if it's being underreported, then I need to, if it's not being reported correctly, I don't get that information. Now the officers may still see it. If the officers are engaged with their community as they walk the block, Miss Johnson, who's on the porch or in the window, may see, hey baby, that corner house got a problem. I may pick it up there, but I still need the data to lead this agency because that's what we're led by.
Yep, I agree. Yep. Thank you. And for the second question, the health department, you know, you guys have come out, we did some neighborhood walks. You guys come out, needle exchange, things of the nature. We did all that kind of stuff, which was really great, and we appreciate it. We were able to help close to 13 individuals during that time from the walk. But again, for some reason, it just seems like we're just attracting, you know, those individuals back to that community. Even we notice, again, those that we've helped, some of them have gone on to get the services, some of them have come back, right? And I'm just trying to figure out how can we, with the health department, kind of, you know, we're holding their hand, but kind of really walk them through the entire process of recovery. Because some of them just don't want it. Like when you ask them, look, here's the information, this is what I can help you do, blase, blase, is more of, oh, can I get you something to eat? Can you just give me a couple of dollars? I need to get out of the gate. That's the conversations. I gotta get well. And again, what do we do? What can you do as the health department to help us, you know, in the council, in the community, to really get the services that those individuals really need, as opposed to them leaving and then coming right back again?
Thank you, Councilman. I appreciate your observation and comment. So I think it's a complex problem, as I mentioned. You know, our approach in the health department is to meet people where they are and meet people where they are today. We know that individuals may enter into treatment and it may not work for any number of reasons, which we've also kind of talked about here today in terms of, is the treatment meeting the need of the individual? We also know, you know, sometimes individuals will go into treatment more than one time, you know, that they will go in and out of treatment sometimes. So it's about meeting people where they are in the moment in terms of our health department programs. I also think you're raising just the complexity of people's needs outside of their substance use issue in terms of, do they have housing? Do they have access to food? Again, all of these are things that came up in the needs assessment and are addressed in the strategic plan as areas of focus in terms of our planning and use of the restitution funds. But there are a number of complex factors at play in every individual's life that affect their ability to be successful in treatment.
Thank you for that. And then one last thing, Mr. Chair. And the reason why I say we need to get on this, and it got to be a holistic approach. First of all, thank you to Hopkins. I was able to take some young people to Hopkins today. That was part of my youth work crew. And what was done today was teaching them how to revive someone, right? And I think it's important that even us as a council, that we get those trainings also, because it may be a possibility where we can help revive someone that's in our, you know, respective districts. So, Mr. Chair, that I would like for us to really have that training. As when I seen those young people really engaged today in that training, and Hopkins was willing to provide that training to us, if you could please add that. And last but not least, I'm sorry.
I said, sorry, I was mouthing. The health department would be more than happy to provide a training for you.
Okay.
Thank you, Deputy.
It's just, today when I was with the kids, Hopkins offered all those things, and, I'm willing to, whatever, I just want something to work. But last but not least, I think one thing I want to add is that, a lot of times I think when we see the uptick in even the juvenile crime that we see in our district, even though crime is going down like overall, but I'm seeing the young people that are robbing and stealing and doing what they're doing because they're seeking those drugs. They need monies for those drugs. And we gotta find a way to, again, is a holistic approach what we need to take, but we gotta find a way because it seems like we're creating that next generation of addicts. And we need to, get a hold on it like as soon as possible. So that's it for this evening. Thank you, Mr.
Thank you, Councilman. Councilwoman Porter.
Thank you so much, Mr. Chair. I want to talk about two things that kind of I've been really focused on. One is data interoperability, and I want to kind of pose this question to Hopkins. One of the major issues that we're dealing with is connection between the hospital systems and substance abuse and recovery homes. Have you all leveraged any influence? I know you all are really looking at this problem very deeply, and so just wanted to see if you all are engaging in that work. Because one of the reasons why I bring that up is because, one, you have persons that are going from the hospital ED to substance abuse recovery clinics, substance abuse and recovery homes, and there's really no continuity between the care. And so to kind of elaborate on my colleague's point from the 13th, that continuity of care coordination is going to be ever so important for our hospital system. So can you elaborate on that, please?
Sure, that's a great question. So part of our work with B-Corps is actually specifically to address that, because so often care is siloed, and if someone goes to one program, that program has no idea what happened before that. So we're trying to create, working with the Baltimore City Health Department, a system that links everything together so that people know, it links EMS to hospitals, to hospital peers who referred someone to a treatment program, and will know if they showed up at that treatment program, because right now nobody knows if someone showed up somewhere after they were referred. If someone shows, right now, individuals who go to methadone OTPs, it doesn't go to PDMP, so we don't even know that they're in that program. So we absolutely have to do a better job of linking all the pieces so that we do a better job of knowing where people have gone, how we can help them the best, and what hasn't worked, so that we'll try something different.
Yeah, and one of the other reasons why I bring it up, and I'm so grateful that you mentioned PDMPs. That was one of the issues that I worked on the Hill, and we still could not figure it out, how to connect the systems between non-hospital institution partners and those that are hospital institution partners. So I'm familiar with B-Corps, but I want to make sure that we are looking at hospitals versus non-hospitals, because if folks are going to the ED for that type of care and then they're going to non-hospital institutions, we need to make sure that, one, they're getting that connectivity and continuity of care, but if there are any resource gaps that are needed. And so I'm hoping that you all are kind of looking at that perspective as well.
Yeah, I think that's all very important. Thank you, Councilman. And the other piece we're trying to do is get OTPs to voluntarily report to the PDMT. It's so essential. So I appreciate your help.
Yeah, and I'm sad that we're still here 10 years later. I'm sad that we're still here. My next question actually has to do with the intermediary care between when a person gets an overdose and when they go into a substance abuse or shelter. One of the proposals that I've often shared is that we need some sort of intermediary care that has varying levels of acuity, but also that they are able to get that wound care and then a warm handoff to the hospital. One of the major pushbacks that I receive is, of course, funding. Funding is a major issue. Number two, how and where would that go throughout the city? Because this is not a overconsumption site. This is not a safe injection site. This is a intermediary wound care center, so that once they are stabilized, they are able to go into the shelters.
So that's a excellent point, because there has been historically a void for people with especially wounds or needing continued intravenous parenteral antibiotics after leaving the hospital for them to go to a safe place. We're starting to work with Helping Up Mission. So Helping Up Mission now has a program, it's both men and women. Helping Up Mission actually also is taking pregnant women as well. But importantly, we've initiated a linkage with the Helping Up Mission but we need more than that. We need more places.
Yeah, and the reason why I bring that up because as we are seeing with the overdoses concerning xylazine, we're going to see even more, and tranq, we're going to see even more and more exposed wounds, and then we're going to see even more and more. And colleague Councilman Glover, to your point, we're going to see even more people in community because they are not afforded an opportunity to go into a shelter or another place where they can safely be. And so we gotta, to round out this point, when we are looking at this system, we gotta really understand the constraints and place resources where the constraints are instead of doubling down on already existing resources where we don't need any more money. Thank you.
Thank you, Councilwoman Porter. Councilman Gray.
I think my question has been answered in a way. It was particularly on silos and how we have various different agencies here, but the interconnectivity of the data and sharing it in real time. How do you guys work together? And I ask this is because I immediately think at a particular corner, doesn't matter where it's happening in Baltimore. The fire department responds, EMS responds to 3 overdoses. They hand out Narcan. Does that information die? Does it go to the health department? Does the health department then step in with resources? Does the police officer then turn and try to disrupt that corner? Do we have that type of system in place? Are there any conversations that are happening when these incidents happen? And this is not to highlight Penn North because obviously that is like the worst case scenario, but the goal is to prevent a corner that is nothing into a bustling corner. And so if, as DC Jones said, if you hear from that neighbor that says, hey, I think something's happening on that corner or in that house, flipping around, then they try to disrupt and then they tell you guys, hey, we should be on the lookout for overdoses. And if so, can we have resources here? Are you guys working in that way? And if you are, can you talk to us about it a little bit?
I can start, if that's okay. Would you like this? I can start. What I can share is a few areas where there is some activity ongoing, but there is room for improvement. The health department does receive data from EMS. We receive that data daily, and we do analyze it and look for spikes and clusters of overdoses. And we produce an overdose cluster report that is shared with partners who have signed a confidentiality agreement and who have capacity to provide outreach and education in naloxone. There's some room for improvement with that. We've been having some conversation about it, certainly in light of what happened at Penn North a few weeks ago, and just always want to be thinking about ways that we can improve that. The health department is also part of a work group that is coordinated by Monzi, and we participate in it along with Director Whaley, and that includes HIDA and some other partners, where we talk about public health interventions along with public safety activities that are underway in some areas. Sorry, I don't want to say anything I shouldn't say about police activity, but we do have a work group that we participate in and work with Monzi around thinking about how to provide public health resources in communities where there is law enforcement action taking place.
Yep, so Councilman, to the deputy's point, yes. So yes and no. So right after this meeting, some of us will be attending overdose stat, right? I need rescue stat for all of the stats that I am in, but it's a great thing, right? I will say that it's good but improving. It has gotten a lot of people to the table that need to be there, a lot of stakeholders, because what we do look at, I know we were in the command center last week in reference to the overdose, and we really sat down with all of the partners and stakeholders to identify what was going to be the basis for what would trigger a all-out response. So I think we ended on 3 incidents within a certain time frame, within a specific geography, would be an all hands on deck. Hey, we got something, let's get it early, right? But I will say for us on BPD side, when we do have those, we do look at it analytically in reference to an organization, a product, analyzing the product. So we do look at that in reference to, do we have something? Is it a one-off? Is it a something where, as the deputy said, unfortunately for the demographics of 50 to 69 and 60 to 69, unfortunately, is it not a bad product? Is it just someone, for whatever reason, their body just can't take it anymore? So we have to look at all of those things, and it may just be a one-off, or is this something involving the makeup of this product that we really need to get out? We want to get out on all of it and address everything, but I will say that we are looking into it. We do investigate it. We do work with our partners, be it off of ODMAP or anything else that we may see something going on. There are conversations going on. Overdose stat is helping to funnel some of that, but as the deputy said, it could be better, and there's room for improvement.
I'll just close it out real quick. The non-fatal overdose data we share with the health department, we share with the police department. The fatal overdose data is strictly a Maryland Department of Health thing. We wouldn't know that short of somebody having a needle or something in their arm. But what we've done over years of evolution, I remember this goes back to 15, 18, we're reporting on people that react to the administration of Narcan, because that's, or naloxone, that's what it works on. The problem, like the incident just happened, like at North in Pennsylvania, that line of thinking is a little bit out, because the drug that we were dealing with was a little bit out of the ordinary. So we've had to expand that, but we do share that readily. I would challenge you with some of the changes with B Corps and the homeless people coming to the street, that we're really going to have to do some data sharing agreements, because I'm bound by a lot of things with HIPAA related stuff. So we're definitely going to have to get some of the legal in there to be able to freely share that with that next evolution or iteration of what we're going to be doing. So,
and thank you all for those answers, because that's what I was looking for. I think in order to curb any type of crisis, all parties involved need to be able to share information freely, and everyone has to use their expertise and their area of expertise in order to stem what's going on. And so this wasn't to call anyone out. This is just to ask you, thank you guys for what you're doing now, but to push you more and more and more to improve those infrastructures, because folks need it in every neighborhood. And for the people that are coming to Baltimore for that help, that continue to put strain on our systems, they need it too. So if you're here, we want to make sure that we're helping folks. And so I do appreciate that answer. And I just hope that you guys continue to build up those infrastructures to make sure that we are helping as many people as possible. So thank you. That was my question.
Thank you, Councilman. I've just got two more questions. One of which is for the health department. And one of the things I requested in advance of the hearing was some sort of estimate of people who were suffering from addiction, and more specifically, probably untreated addiction. I know those numbers exist out there. I don't know how good they are, but my thought here is I think the immediate goal for us is to reduce overdose deaths. But after we've done that, the goal is then to break down the addiction across our city. So while naloxone is a really important tool for reducing deaths, I think the next step is to address the addiction. So do we have any estimate of that, or start there?
Is the question, is there an estimate of the number of people with opioid use disorder?
Yes.
So a number that was promulgated about a decade ago by the health department was around 25,000. As we talked about on Friday, estimating is challenging. We do know there are a few academic organizations across the country who are looking at different modeling and things to better determine what those numbers might be in various states and jurisdictions. So 25,000 is a number that the health department has promulgated in the past, but I'm not sure that I am completely comfortable in that number today.
Yeah, I appreciate that. Thank you. I think it's important for us to try to figure out some way of measuring that, because I feel like ultimately that's our outcome. That's the thing that we ultimately want to impact most. And if we have a sense of how many people are suffering from addiction and how many of those folks are suffering from untreated addiction, it can give us a sense of the scale and scope of the work we need to do. I don't know, I have nowhere to start, no idea where to start there, but I certainly would encourage us to do whatever we can to figure out some way to get a decent estimate on that, one that we can report on at least yearly. Which leads me to my second question. I have not said the word buprenorphine yet. I was really excited to see the slide with the spot van increasing the distribution of buprenorphine in 2024. That makes my heart happy because I know how important that medication can be towards people dealing with their addiction. Do we have any data that can, speak to the outcomes from that distribution? Do we have more people now in treatment, or do we see any subsequent reduction in overdoses or overdose deaths in the area following the distribution of the spot van?
Those are great questions.
I'm good at giving good questions.
Not sure that I can answer all of them, but I'll say, I think one of the things that we continue to innovate around with the SPOT program is looking at retention and what does retention mean. There aren't any national standards for retention in care, and so that's one of the things we continue to think about and explore. As I mentioned in the presentation, we've really been focusing on how do we reduce the barriers and again, sort of meet individuals where they are. This is a mobile program, so we're going out into communities where people who use drugs are congregating. And so it might be meeting them where they are today around needing clean syringes or on giving them naloxone, and you build that relationship over time. Or, they're looking for an HIV test today, or, whatever it is. So it's building relationships. I think it's understanding that this is a population that routinely have gaps in care and cycle in and out of care. And so again, just being able to meet them where they are when they present to the van. We have been developing relationships, as I mentioned. We're working really closely with Charm City Care Connection on the east side. And so, folks know that they can receive services on the van, and then they can also go into Charm City Care Connection and receive other services there. That's been important in building sort of the retention and care piece. We've also been developing a lot of relationships with pharmacies, because actually access, it's one thing for the doctor or the nurse practitioner to write the script, and it's another for these individuals to go to a pharmacy in the community where they are and have the pharmacy actually fill the prescription. So it's developing relationships with those neighborhood pharmacies so that folks can actually get their medication when they go. It's having bridging prescriptions through the telemedicine line. I mean, there's been a lot of concentrated effort on reducing the barriers to get people into care and keep them into care with the SPOT program.
I appreciate that. And obviously I'm a big fan of buprenorphine, and I appreciate how useful it can be for folks. So encouraged by the increase in distribution, of course, think it's great for us to do that and much more. Those are all the questions that I have today. Any further questions from the committee? I want to thank the panelists who joined us today, who came out to add their perspective. You guys are, as you alluded to, really important partners in getting this work done. In times where the city maybe has to change its focus, you guys are coming to the table and helping us account for those differences. I really want to appreciate the departments and all the great work that you guys have been doing. We're going to need to figure out a way to be smarter about the work that we're doing. And I think it's in part some of these difficult questions that we don't yet have the answer to, that we'll have to figure out how to answer those questions and make sure that we continue to move forward as a city and be as empathetic as possible, as transparent as possible, as we continue to work on this issue. We will have another hearing in September. That will be focused on the city's plan. And for those that are not aware, actually, I'm going to ask somebody here to give me the website. Maybe Sarah, you could share the website for folks that may be listening in. We would love your input on the plan. It's very important that people understand what the city is trying to do so that you can understand if any role for you exists where you might want to put that in. But Sarah, I am stalling so that you can give us the website.
You can find it on the health department's website. There's a landing page for the opioid restitution fund, and the strategic plan is linked there.
Excellent. Thank you. With that, this hearing is in recess until we have our next one in September. Thank you.